يا جماعة, please. I recall I was examining with an examiner, and he asked this question. And he wanted to know what ligament structures attached to the distal radial ulnar joint. And you should include, if you include one, mainly the triangular fiber cartilage, it is important because they will end up having wrist pain. There is a complex relationship of the radius to the ulna and carpal bones. Damage to the distal radial ulnar joint is associated with what we know the Gagliazzi fractures. You should know about the compartments of the forearm. You have three compartments. You have the posterior compartment, which consists of the extensor muscles. You have the anterior compartment, the flexors, and you have the mobile wad. And these include the brachioradialis, the extensor carpi radialis brevis, and extensor carpi. إذا سألوك بالexam, what are the three compartments of the forearm? You should list as what is listed here. You should know about the radial nerve and be aware of its posterior interosseous deep branch, which runs along the neck of the radius proximally, and beware of its sensory superficial branch distally. Okay, so keep this in mind. As it goes posteriorly, it becomes known as the posterior interosseous nerve. The median nerve, it is of midline location and is in danger. It's under a transverse retinaculum with structures, and if any injury occurs over there, you could possibly injure it. And you should know about the anterior interosseous nerve, which travels along the interosseous membrane. The ulnar nerve travels along the ulna. It's subcutaneous in the elbow, in the cubital tunnel, and in that region, two heads. The ulnar artery is the girlfriend of the ulnar bone and the nerve, and the nerve. So you have to pay attention to this. The mechanism of injury. Forearm fractures occur from low energy trauma, and it can be due to a direct load. This is the nightstick fracture. لما المريض بيجي بده يرفع ايده يدافع عن راسه تجي ضربه بالعصايه على الulna. And this is an isolated ulnar fracture where the arm is used to block a blunt object. It or can be due to indirect transmission of forces. Montesia fractures, which includes the ulna and radial head dislocation. The ulna is a fracture usually at the junction of the middle and proximal term, where axial loads is combined with rotation, as with a fall on the outstretched arm. Likewise, Gagliazzi fractures are distal radius with distal radio-ulnar joint disruption. بعكس المونتيجا. المونتيجا proximal radial head dislocation. Gagliazzi distal radius and distal radio-ulnar joint disruption, where axial load is combined with pronation. The mechanism of forearm fractures. Forearm fractures from high energy trauma may be due to direct or indirect forces. They may have associated injuries. They may have associated fractures. It can be part of a floating elbow. You can have multiple segments with deformity, swelling, and pain. Don't miss injury to the joint above and elbow, below the wrist. Don't miss a compartment syndrome where the patient comes with severe pain and on stretching has pain, plus the 3 other P's. Open wounds. Remember, the ulnar border is subcutaneous, and even superficial wounds can expose the bone. Associated nerve injuries, especially with open fractures, obtain orthogonal views in AP and lateral x-rays of the forearm and the elbow. Identify localized swelling, tenderness, and decreased motion. Carefully examine any wounds over the ulna. Palpate the elbow, especially the radial head. Palpate the wrist, especially stability of the distal radio-ulnar joint. Carefully assess neurovascular function for all nerves of the forearm and hand. Assess firmness of the compartment. Yani, is a distal compartment archy? Is it rigid? Is it hard? Then you should suspect the possibility of a compartment syndrome. Pain with passive stretch, and measure the pressures if in doubt. In the university hospitals, we have all the Stryker stem system with a needle. It tells us the approximate recording of the tissue pressure. You have to have good quality anterior, posterior, and lateral x-rays of the entire forearm, including the elbow and the wrist. In our staff meetings, if the resident comes taking one x-ray of the forearm without the elbow or wrist, believe me, we give him hell and we give him a warning sign, because this is the basic teaching we like to give. The radial head must be aligned with the capitellum on all views. Simple ulnar fractures on AP, but the radial head is dislocated on the lateral. Look at this. Is a Montesia fracture. Proximal third of the ulna and the radial head. If you look at the AP view, you see that the head looks reduced. And you call your doctor, the head is reduced. In the morning you come and you take a lateral x-ray and you see that it is dislocated anterior. So it's a more. Keep this in mind. You should do the next necessary radiology, radio imaging. The relationship of the distal ulna and radius must be symmetric with the opposite wrist. This patient developed a Galeazzi fracture of the radius. But look, distally, the distal radio-ulnar joint. The distal radio-ulnar joint is subluxed. And if you look carefully, there's a small fracture of the ulnar style. What is attached to this? This is the triangular fibrocartilage, therefore it should be torn. If you look at the gap between the radius please pay attention. This is a distal radio-ulnar joint injury as a result of a Galeazzi fracture. You can have isolated fractures of the radius or ulna, as we spoke about the nightstick fracture. You can have fracture of both bones and no ligament injury. You can have fracture of one bone, ligament rupture. You can have a fracture of the ulna and radial head dislocation, as I spoke. I'm repeating this because we ask this quite often, and you have to know about the Galeazzi. You have to know classification. I personally am lousy for classifications, and I don't ask about classification except the very known classifications. I don't ask in the exam. So it's nice to know one classification of one area. If you look at the ASIF classification, A is a simple fracture, no comminution. B is a wedge fracture, a single butterfly fracture. And C is a complex fracture, which could be segmental and comminuted. This classification is easy to remember. And usually, as I know, the AO are very complicated in other areas. So I chose the easy area to make use of the AO classification. Okay. Now we're going to, I don't know what is really happening here. ليه لزقت علي هيدي. I'm not going to go through these in detail. Let me see. Type B. You have to look these up. And as I told you, Dr. Khalid is making a copy for you. And I mentioned about all of these. This is a type C fracture of the radius and ulna. This is a type B fracture, and this is a type A fracture. Okay, so you have to keep this in mind. Use this classification, which is good. And always try and maintain and get an excellent reduction of both bones. The radius is important. You have to allow for the bow to return. Otherwise, you'll get limitation of pronation and supination. Now, the radius, they asked me, which bone should we operate first? I tell my residents, operate the side in which you think is easier. For instance, if you have a segmented fracture of the radius and you have a simple fracture of the ulna, what I do is I operate on and get a perfect anatomic reduction, then I move to the radius. Why it will regain the length to some extent and make it easier for me to reduce the segmental fracture. So this is operate on the side was easier. Don't forget the radial bone. Don't forget the radial bone. If you forget it, the patient will complain, say limitation of pronation and supination, and he won't be happy. If you have a non-united fracture and you want to put him in a long arm cast, you can, but you need to follow up your patients because many of these slip. You have to pay attention. Okay. Now, even with open reduction, you have higher rates of union and excellent function. This is a nightstick fracture, which I have spoken a lot. This is the treatment. What do we do? This is a fracture of both bones. يعني هيدي خربت لي حياتي. as treatment of forearm fractures. هيدي ليه ما حل؟ ليه؟ حلت بالأول وبعدين ما عادت حلت ليه؟ ما بعرف. خالد في شيء أسود جاي لعندي على السكرين.
السكرين واضح يا برو.
شيء أسود يعني عم بتغطي لي كل شيء. يمكن حدا من برا عم بجري. Whenever you have an unstable fracture of the radius and ulna, there is no doubt that you should operate. And I usually operate after the age of 10. I usually put them in plates. I like them. Many times I use the malleable pins. But the problem is with this, you have to incorporate them in a cast because this does not. You should put 3 screws, approximately 3 screws, this 5 plates in these patients. The humor is when you're putting a plate, you should use a 4.5 plate. With the hope that the wound would heal. And once the wound is in good status, you can apply internal fixation and remove your fixator. You can use also intramedullary nailing in both bones, but you have to realize that the radial bow will be lost. Okay? And they don't like. We use it in pathologic fractures and impending fractures, protects the whole bone. Yani, to make a resume of this, years of age, you put plates. I use the 3.5 plates, locking plates, and I usually aim at pin, which is called matizo. Fracture. I usually put the plate on the ulna and I reduce the head of the radius. If I find that the head of the radius is not being reduced due to of the annular ligament, I have to go ahead, operate, and remove the annular ligament from its. Be very careful. At times, nowadays, these autostrats were getting more and more float elbows. A true extension will give you. How many times do you have to say it? Oh, okay. So this is enough. This is an intramedullary rod. They left the patient as is. The patient continued to having problems. On taking follow-up X-rays, the patient develops intramedullation. They don't help in the bow. If you pay attention, this rod was put more proximally so as to maintain the bow. Don't forget that you can have a compartment syndrome of the forearm. Don't forget about the 3 compartments. While applying the plate, I repeatedly say, restore anatomic reduction. Restore ulna and radial lens. Prevent subluxation of either the proximal or distal radioulnar joint. Restore rotational alignment. Restore the radial bow. This is rotational function of the forearm. If you know these from this section of the lecture, it is enough. Now, about the approach, that is an anterior approach where you go ulnar to the brachioradialis. You can expose the bone. The pronator teres will be underneath you if you're going midway. And the artery, you can retract it laterally together with the nerve. You have to pay attention to the sensory nerve when you're going in front. There is an approach which is called the Thompson approach if the fracture of the radius is more proximal. When you're doing an ulnar approach, you notice the ulna is directly under the skin, but your incision should be over one of the muscles. Why? Because if you do it directly over the bone, the wound can become adherent to the bone. So this we don't want. Okay? We should always bone graft if comminuted or there is loss of bone, and if 1/3 the cortical circumference is lost, interfragmentary compression becomes impossible. So you have to depend on bone graft. Use 3.5 LCDC or DCP plates or lock plates, 7 cortices in each fragment, including a lag screw. So you have to pay attention to following these principles. Reduce and provisionally fix the easier bone first and then the other. Sometimes it is necessary to loosen fixation on the first bone to obtain a reduction of the second. Use indirect reduction techniques, preserving soft tissue attachments. Periosteal stripping is a must. I've noticed from our residents as they reach the fracture beam called periosteal elevator and they want to strip. This increases the chances of non-union. You should use narrow retractors. They are placed to avoid penetration of the within 35 days. 3 to 5 days, I apologize. So these are points. You have to pay attention in forearm fractures of whether the interosseous membrane is torn or not. You should regain the length of the bones. Otherwise, the patient will have either pain in the elbow or the wrist. I've done many repetitions in this lecture so that you will remember what I'm trying to tell you. The length of the ulna is vital to the forearm. stability and must be maintained to prevent wrist pain and impingement. The bow of the radius is vital to the forearm rotation, and length must also match the ulna to avoid wrist symptoms. Successful functional outcome correlates directly with accuracy of anatomic reduction. This is a 50-year-old male with comminuted both bone forearm fractures after a motor vehicle accident. Plates were applied to both forearms. If you pay attention, the screws were 6 in number, 3 on each side. If you have a fracture, you can fix it with an external screw. You these basics, not for the attendings, but for the residents. This is a 33-year-old male with segmental open both bone forearm fractures after a conveyor belt injury. This is the reduction on this fracture. If you notice around the fracture, little screws were put. Why? Because to get relative fixation, to maintain not a rigid fixation. Okay? Keep this in mind. The ulna is approached along the subcutaneous border. The skin incision muscle instead of bone, either slightly anterior or posterior. A wide skin bridge should be maintained from the radial wound. Don't operate on both bones of the forearm through one incision. You should have separate incisions, a radial and an ulnar approach. If you operate them through both in one incision, the incidence of synostosis is high. So you have to follow the anatomy, but each one is totally independent, but maintain the proper anatomy. This is the ulna that we do, and this lies in between the extensor carpi ulnaris and flexor carpi ulnaris. And finally, we go through muscles to reach the ulna. The radius, this is the brachioradialis. We retract the radial artery and nerve laterally, and then we reach the pronator teres, and then we have the whole shaft anteriorly right facing us. Okay? This is it. You can separate the pronator teres, but have to reattach it if it does, or just remove a few fibers from it, and it would give you approximate. The posterior approach, the distal plates may irritate the long thumb abductors. Proximally, be aware of the deep branch of the radial nerve. This is a posterior approach, and this I personally don't like. First of all, it creates danger on the radial nerve, and it is more difficult. I found it easy to approach the radius proximally than through the Thompson approach. But you should know that there is such an approach. This is it. Look at the radial nerve. The radial nerve is facing you through the supinator. And believe me, you cannot be at ease when you're operating using this approach. This is finally the shape. Early surgery is desirable. You have an easier reduction, and you can avoid preoperation. Delayed surgery done if you have poor soft tissues and other injuries involved in the body that will delay the surgery. Special cases, fractures associated with joints, you should keep in mind. Galeazzi Montigia combined patterns, and fractures associated with other injuries, such as the floating elbow and open fractures. We spoke about these so much that you have to get the perfect reduction. You should aim at reducing the head in Montigia fractures and Galeazzi fractures likewise, and you will reduce the distal radio-ulnar joint in Galeazzi. And if necessary, look at the triangular fibrocartilage arthroscopically. If it's torn, you should repair it. Okay? So don't forget this. Gunshot injuries, a bit. Let me see. Fractures can occur anywhere in the radius or associated with fractures of both bones your ulnar joint. This is quite common. See, I'm not going to go through it again. Just showing you the plate of how it was put and how the reduction was aimed. This was the Galeazzi. You look at the ulna, look at the distal radio-ulnar joint. There's a large step. Beware of the triangular fibrocartilage. This is following a reduction. You see you brought the radius back to length. The distal radio-ulnar joint closed. Okay. So these are all of our important fractures in this case. This is in other pain. Now, مشكل dislocation لازم تقوله Montigia. There are some congenital cases. This patient had a fracture, but the ulna, and that's it. This shows you after healing how the head is. It's now no longer in relation to the capitellum. Okay, so don't forget these. This is what I've put these as several of soft tissue. It's best. Some even put pins, but I will tell you, putting a pin is a call for non-union. You have to put a cast over it to prevent malrotation. This is a case of both bones where plates were applied. So one point I want to tell you, when you have a high velocity gunshot wound, you should treat it as though you're treating a Gastillo grade 3B. If you have a low grade velocity, do not require formal debridement. There's a higher incidence of neurovascular injury, compartment syndrome, technical difficulties to increase comminution. And treatment is open reduction and internal fixation with plates. This is in the low velocity. In the high velocity, you have to put an external fixator, I presume. This is a high velocity 20-year-old male showing you the injury. A plate was treated over here. So when you have a big gap, you have to get the fibula, a vascularized fibula graft, and you put it, and this is the result. So coming to complications, the early complications of compartment syndrome is not to forget it, keep it in mind, examine the patient well, and you won't miss it. You should also search for neurovascular injury, and in infections, give the proper antibiotics. Late complications are non-union due to hardware failure, infection, malunion, synostosis, and persistent pain. Now, about compartment syndrome, it's usually due to high energy trauma crash. It can occur with low energy. It can occur with gunshot injuries, and the predisposing factors are vascular injury, coagulopathy, limb compression, crush injuries. The early diagnosis is, as I have repeatedly said, a high index of suspicion. They have pain on passive stretch. They have palpable firmness or tightness of the compartment, altered sensation and paresthesias. They have less than 30 millimeters of mercury difference between the compartment pressure and the diastolic pressure. Early treatment is the best chance of recovery. One should release all three forearm compartments and even the carpal tunnel. Should prevent iatrogenic compartment syndrome by not closing the fascia during surgery, by obtaining good hemostasis at surgery. Ya Jamaa, when I operate on a forearm fracture and I go out, I tell the resident, don't suture the fascia around the anterior muscles, because you could expect some bleeding and swelling, and this could lead to a compartment syndrome. So you have to pay attention to this. You should do as possible proper hemostasis. This is a patient. You can even have a compartment syndrome in a patient with a compound fracture. Be very careful. Be very careful. This neurovascular injury is not very common, can be iatrogenic, as I told you, especially in the Thompson approach, where you can damage the posterior interosseous nerve with proximal radius approaches. In the front anterior approach, you can damage the superficial radial nerve. You can also injure the anterior interosseous nerve during reduction of the radius. And in these cases, on follow-up, if there is no recovery, you should explore the nerve at 3 months, at the end of 3 months. Malunion after forearm fractures, there is loss of motion with increased 10 degrees of angulation. As I told you, the radial bow is important. You can have also decreased grip strength with a drop or decrease in the radial bow. So you lose the rotation and your grip strength becomes less. You should treat this with an osteotomy and repair. Synostosis occurs in 1 to 8%, and you can have a fracture of both bones at the same level. It occurs in patients who have head injuries. It can occur if you operate a patient at the end of 2 weeks due to the comorbid state or due to multiple injuries. And I don't want to overemphasize or underemphasize. A single incision should be prohibited, and penetration of the interosseous membrane by bone graft or screws, bone fragments, or surgical instruments. All these as synostosis. Treatment is resection with interposition. It restores motion in 50%. Now, if you have this bone formed, you can wait 1 year or until the metabolically inactive bone on bone scan. But later, don't wait. This is a patient who is 20 years. He had a vehicle accident. He had a head injury. He had a failed attempt at open reduction and internal fixation elsewhere. The treatment included open reduction, internal fixation, and the synostosis developed. So what are the options now? Wait until it's mature. You can do a bone scan, which would interpose fat. I interpose fat and gel foam. And it is successful, I would say, in 50% of the cases. This is following a resection and the range of motion at 3 months. Don't forget about the risk of refraction. Many times I apply a plate and the patient comes at 10 months. He says, the fracture united, please remove the plate. If you notice at the beginning of this lecture, I said, I usually use 3.5 plates. I don't use 4.5 because it gives you such a rigid fixation that it would create stress rises. You can have fractures about these. Now, if you remove the plate and you remove the screws, the sides of the screws are weak areas. So keep this in mind, and you can get a refracture. Infection and nerve injury and other complications do occur, and pain may persist if you have a patient complaining of pain because he feels that the plates are causing it. Many times you remove the plate and the patient comes back 1 month and tells you, I still have pain. So you have to pay attention to this. The benefits may not outweigh the risks. 67% have residual symptoms. 9% of patients are worse, including the weather, the exercise pain, the skin and tendon irritation. This is a 33-year-old female with a plate, removal 1 month previously with a persistent ulnar pain. Patient had a refraction. It was not a non-union. And this is at 1 month how it appears. Was the original plate technique adequate? I would say no. And this patient had a 4.5 plate. I don't like these in the forearm. So the original technique was suboptimal as judged by the residual screw holes, inadequate number of screws, and no lag screws. So you have to pay attention to this. We don't like to put many screws around the fracture. We prefer in putting longer plates, minimally 3 screws on each side. You have to keep this in mind. I'm showing you these because we run into them. Poor technique, failure to create a stable contract, too few screws, improper compression, over-aggressive, iatrogenic damage to soft tissues, poor initial fracture characteristics. So مين عم بيحكي؟ في مشكلة؟ خالد في شيء؟ يلا I finished. I would speak about non-union, aseptic non-union. It requires revision, fracture, fixation, bone graft, segmental bone placed with intercalary bone graft, iliac crest if less than 3.5 centimeters, fibula graft if it's more than 3.5 centimeters. So you have to pay attention to this. Let me see if there's anything. Infected non-union follow the same principles of aseptic non-union. Achieve mechanical stability, restore a viable biologic environment, follow principles of infection control, removal all infected and non-viable materials. I'm just giving you these examples. I won't go through them because they're taking much of the time of this lecture. Let me see if we finish. Yes. Now I'll take a rest for 5 minutes. Wow. Spoke for nearly 2 hours. Nearly 2 hours, eh? Okay.
اوكي دكتور.
Khalid, إذا في شيء أسئلة أنا I'm relaxing for 5 minutes. But they can ask me.
اوكي شير اوكي.
Is it good and clear so far?
Very clear bro.
يا أخي, I repeated in lecture of the forearm many times so that they would not forget. It's very important. Okay? بقى إذا في شيء سؤال يسألوني.
شباب في سؤال.
عم بيقدموا الفحص يمسكوا على الويكند يمسكوا هالسيكريتس اوف اورثوبيدكس ويحفظوه عن الغايب.
رسلت للمجموعه كامله وهم بيسمعوك وان شاء الله بيحفظوا خاصه المتقدمين يعني. ايوه
بقى ما بعرف. اوكي عم برتاح، عم بريح صوتي، عم بريح صوتي.
يلا ارتاح الله يحفظك.
Fractures of the distal radius. Fractures of the distal radius usually are classified either as extra-articular or intra-articular. Numerous eponyms are applied to fractures in this region, resulting in considerable confusion in the literature, especially concerning the differentiation of Barton's from Smith's fracture. Distal radius fractures are the most common orthopedic injury. And generally, the diagnosis is made clinically and radiologically with orthogonal radiographs of the wrist. When complicated, CT scan is indicated. Treatment can be non-operative or operative, depending on the fracture stability and fracture patient age and activity demands. It accounts for 17.5% of all fractures in adults. It is more common in females. Why? Because of osteoporosis. It has a bimodal distribution, meaning younger patients, it does occur, and it's usually due to high energy mechanisms. Older patients is due to low energy mechanisms. 50% of fractures of the distal radius are intra-articular. Osteoporosis is a high risk factor. A high incidence of distal radius fractures occurs in women greater than 50 years. Distal radius fractures are predictor of subsequent fractures. I want you to sit and think, how many of your patients came with a radius fracture distally and came later with a fracture of the hip? It is a predisposition, and it tells you that an osteoporotic process is setting in the patient. You should always warn the patient and make sure that the patient doesn't have osteoporosis. If he does, put him on a treatment regime. DEXA scan is recommended. Distal radio-ulnar joints are usually associated with it. Radial styloid fractures indicates a higher energy mechanism. Soft tissues injuries are seen in 70%. And these are, we spoke about it in the previous lecture, the triangular fibrocartilage complex injury, it occurs in 40%. Scapholunate ligament injury, 30%. Lunotriquetral ligament injury, 15%. Matensu, when you have a fracture, distal radius, you shouldn't say this is a colleague fracture. We don't use this term nowadays. We say it's a distal radial fracture. Is it comminuted? You say. You have to say, look at the articular surface and see, is it best separated? Exactly. Because the surgery will be different. It's responsible for 80% of axial load articulating with. I'm speaking about the distal radius being responsible for 80%. It articulates with the scaphoid via the scaphoid fossa, with the lunate via the lunate fossa, the distal ulna through the ulnar sigmoid notch, yani the distal radio-ulnar joint. 3 articulations, fossa and the sigmoid notch. Now there are classifications. We speak about the radial column. This includes the radial styloid and the scaphoid fossa and serves as an site for the radialis tendon, and the long radiolunate ligament and radioscaphocapitate ligament. It serves as a buttress to resist radial carpal translation. It functions as a load-bearing platform for activities performed with the wrist ulnar deviation. It holds the carpus out to length. You can see it has so many functions. Okay? It serves as an scaphocapitate ligament that prevents ulnar translation of the carpus. So this is the anatomy you should know. It's a functional anatomy. Read this section, the radial column. This shows you what I'm trying to speak. You have the ulna, you have the sigmoid notch, which is in purple or red, between the distal radio-ulnar all holding the carpus in relation to the radius. So don't forget about the sigmoid notch. Don't forget about the lunate fossa and the scaphoid fossa. The intermediate column is the lunate fossa. It functions to transmits load from the carpus to the forearm. That's the lunate force. Forces from the carpus to the forearm. The ulnar column includes the triangular fibrocartilage and the distal ulna. It functions stability of the distal radio-ulnar joint and forearm motion. Now, you can have depressed fractures of the lunate fossa of the articular surface of the distal radius. So this is an intermediate column, and you see arrows are pointing out as the lunate is migrating proximally, the capitate will follow it. Fracture of the wrist. You should know it. This is a Barton's fracture. You can see it's very similar to a Smith's fracture, but the Barton's is an intra-articular fracture. A Smith's is the exact opposite of a Colles fracture. A chauffeur's fracture. بالماضي بتعرف العربية كيف كانوا يدوروهم. They used to use the crank. At times the crank would fail and hit the radial styloid, resulting in a fracture. A Colles fracture is a low-energy dorsally displaced extra-articular fracture. Smith's fracture is a low-energy volally displaced fracture. So look at this slide. You see the Colles, the Smiths. One is opposite to the other. The Barton's is an intra-articular fracture. You should know the classifications. I don't want to see them because I hate them. I had to study them for 2 board exams, but you should study these classifications. You should study the Freitman, the Fernandez. You should study the AO classification. You have to know these classifications. On physical exam, you should inspect diffuse tenderness, visible deformity if displaced, ecchymosis, and swelling, motion limited by pain. These measurements You have to know the amount of radial inclination. You have to know whether you have a die punch fracture or not. You should see the relation to this line. You should look for radial shortening, which is from one styloid to the other. It should be, I think, 12 millimeters. And you should know about the volar tilt of the distal radius, which is 11 degrees. Okay? CT is indicated intra-articular involvement and do help you in surgical planning. MRI, the soft tissues, the triangular fibrocartilage injuries, the scapholunate ligament in this, and lunotriquetral injuries in VISI. Close reduction and splint cast immobilization, yeah, Jamal, we still use it. We put in the early 2 weeks of fracture, we usually put the patient in a long arm cast. Following reduction, putting it in to put the wrist in too much flexion because we can get a compartment syndrome. To reduce it, you need adequate anesthesia. You should apply longitudinal traction, volar and dorsal pressure to the distal fracture fragment. You should put them in a snug cast. Place. And routinely, you should take an X-ray after 1 week to make sure everything is in place. If it slipped, you can allow yourself to apply another with it reduced. Was because the swelling subsided. Avoid positions of extreme flexion and ulnar deviation, because this could lead to a carpal tunnel syndrome. No significant benefit of physical therapy over home exercises for simple distal radius fractures treated with cast immobilization. Now, we have a certain number of factors by Lafontaine that predict instability. And these include radial shortening is the most predictive of instability, followed by dorsal comminution. Severe osteoporosis, associated ulnar fracture, dorsal comminution greater than 50%, palmar comminution, intra-articular comminution, dorsal angulation greater than 20 degrees, initial displacement greater than 1 centimeter, initial radial shortening greater than 5 millimeters. Complications specific to this treatment. You can have an acute carpal tunnel syndrome, and you know that the extensor pollicis longus passes through the third compartment. The tubercle is irregular, and you can have rupture. On the other hand, if you're doing an open reduction and inserting a DVR plate anteriorly, you can have a rupture of the flexor pollicis longus tendon, especially if the plate is passed the watershed area. And this is called, we asked this question several times, and it is called the Mannerfeld syndrome. Mannerfeld syndrome. Look it up. Now, if you're going to do reduction, first of all, you have the Kapenge intrafocal technique where K wires are passed through the around it and put your pins. You have to do a close reduction and you maintain pins. And this works very well if the fracture is not very comminute. You could have pin tract infections. Now let us speak about open reduction and internal fixation. Distal radius extra-articular fractures need open reduction and internal fixation via the volar approach. Distal radius intra-articular fracture should be done because a flat plate with irritation of these tendons that you can get ruptures. You have to be careful when you're applying. You have to be careful when you're applying these, not to put them too distally. You will be passing the watershed area. This is the most volar margin of the radius closest to the flexor tendons. They can have hyperesthesia over the base of the sena eminence due to palmar cutaneous nerve injury during retraction of the distal flexor tendons when plating the distal radius. New volar locking plates offer improved support to the subchondral bone. Now, when you have displaced intra-articular distal radius fractures, one should consider the place for dorsal plating. Historically, it was associated with extensive tendon irritation and rupture. The technique you can combine with external fixation and percutaneous spinning. Perform bone grafting if complex and comminuted. Volar lunate set fragments may require fragment-specific fixation to prevent early post-operative failure. What are the complications specific to this treatment? Screw penetration into the radiocarpal joint or distal radio-ulnar joint. Assess intra-articular screws with a 23-degree elevated lateral view. Assess the dorsal cortex penetration with skyline view and tendon rupture. I want to mention now at this time, this question. You have to pay attention. If you look at the distal end of the radius, on the dorsal aspect, you see it's a bit concave. So when you take a lateral X-ray, you think that all are of the same length of the most lateral end of the distal radius. When you put the screws of the same length, centrally you will penetrate the cortex. And these are in close association with the extensor pars longus and with the common extensor tendons. So these can undergo a rupture. How can you demonstrate this? You have to take a skyline view of the wrist, leading to a tendon rupture. So pay attention to this, please. External fixation. Technique guides. The distal radius fracture, spanning external fixator. The distal radius fracture, non-spanning fixator. خليني أقول لكم إياه. إذا بسألكم بالفحص, what is the difference between a spanning external fixator and a non-spanning external? The spanning is when you're fixing the distal radius by pins being held in the metacarpals and the proximal radius. So you're spanning multiple joints. The chances for it to change or to lose correction is high. But at times, we are forced to use it. Why? Because the fracture is comminuted. But what we do with it, we use the Carpentry pins in association as to decrease the incidence of this complication. The non-spanning, it means that the fracture is not very comminuted, and you put your pins through the distal end of the radius and proximal radius. This way, the patient can undergo flexion extension with minimal chance of displacement. Do you know why? In spanning external fixators, there is displacement. Because when you bypass multiple joints on flexion extension, the center of rotation changes. So you have to pay attention. Okay? So please, don't forget this. It relies on ligamentotaxia. Place the radial shaft pins under direct visualization to avoid damage to the superficial radial nerve. Avoid over-distraction, and the maximum amount of distraction should be less than 5 millimeters, and excessive volar flexion and ulnar deviation, we don't like it. It causes a compartment syndrome, okay, a carpal tunnel syndrome. So please pay attention to this. Limit the duration 8 weeks and perform aggressive physiotherapy. Malunion is a problem. Non-union also. Stiffness and decreased grip strength is another problem. Pin complications, infections, fractures through pin site, skin difficulties, pin site care comprising daily showers and dry dressing is recommended. Neurologic iatrogenic injury to the radial sensory nerve, also median neuropathy. And don't forget, when you're doing the Perkinji technique, don't forget there's a high incident of reflex sympathetic dystrophy. You pay attention to this, okay, due to stimulus or of the sympathetic. So pay attention. Most frequent neurologic complication. It's seen in 1 to 12% of low energy fractures and 30% of high energy. The risk factors prevent by avoiding immobilization in excessive wrist flexion and ulnar deviation. Distal radio ulnar injury, we spoke, the extensor pollicis longus rupture. And let's see if there's anything that I need. No, I spoke about these. In the past, we used to think that vitamin C was important for reflex sympathetic dystrophy, okay? But nowadays, we found that it's useless. It has no effect. There's strong evidence to suggest the efficacy of prompt physiotherapy, lidocaine injections, ketamine, biphosphonates, sympathectomy, and brachial plexus blocks whenever you have an RSD. This is a patient who has reflex sympathetic dystrophy in both hands, following a double distal radial fracture. So you can see the swelling that occurs. Now we come to scaphoid fractures. Are there any questions on distal radial fractures? I just would like to mention that we operate them always under tourniquet control. We aim for excellent hemostasis at the end. Before closing the wound, we release the tourniquet. We put the plate in such a way that it won't interfere with motion in any direction. We don't like to pass the distal end of the radius, which we call the watershed area. Why? Because the plate will be very close to the tendons and you'll end up having a rupture. You have to not forget the triangular fibrocartilage. If you have a large ulnar fragment, you should respect it. You should pass a pin through it into the ulnar and get a reduction. Because the triangular fibrocartilage, which is an important structure, holds the wrist in proper position. So you have to keep about your mind. Okay? We have scaphoid fractures at the next lecture. Are there any questions? ايش اسئله؟ ها؟
اوكي جو اهيد.
ليك خالد عم بعد لهم اشياء كثير، وشغله ثانيه اخذ الانفورميشن تبعي من كل الريفيو كورسز لحتى يقدروا يكونوا عندهم a broad knowledge. ما حدا بيقدر يقول لي انه distal radius fractures, I did not repeat many of the topics so that they won't forget. Yeah. I would like to stress one more thing. You have the fora, you have the distal radius, and you have the scaphoid. Okay, these are three areas. They all fall on the extended wrist. Why do we get a fracture of the proximal radius and ulnar? Why do we get a fracture of the distal radius? And why at times we get a fracture of the scaphoid bone? Does anybody know? شو يا خالد؟
دكتور جون
سؤال عم بسأله ليش لما بيوقع على الريست extended ليش اوقات تجي بالبروكسيمال راديوس، ليش اوقات الكسر بيجي بالديستال راديوس، وليش بيجي بالسكافولد؟ واذا حدا منهم وقع تحت مني بالفحص يلي رح نعمله هلا رح بسالهم هالسؤال. شو جواب؟ جاوبوني.
يعني واحد من محمد بيقول انه
علي
على
صوتك
حسب
خالد، ما عم
وضعية
بسمع.
دكتور جون، هو بيقول محمد بيتكلم على اساس البوزيشن يعني للفورة.
If rotation, if with supination is
They,
can go with
many
scaphoid fracture. Yeah.
I will tell you وما تنسوها بحياتكم. When
Okay.
they fall on the extended wrist at an angle of 30 degrees, you will get a fracture of the proximal radius and ulna. When they fall at an angle of 65 degrees, they will get a fracture of the distal radius. And when they fall in 90 degrees and more, due to impaction of the scaffold on the dorsal rim or posterior rim of the distal radius, they'll get a fracture of the waist of the scaffold. خليهم يحفظوها وما ينسوها.
ماشي. اوكي.
Okay.
يعني 30.
Now we'll go into scaphoid fractures. I'll give you scaphoid fractures and then I'll rest for 5 minutes. هيك بنخلص من الupper extremity. Okay? نخلص من الupper extremity. بعدين we'll move down to the pelvis, to the sacrum, الباقي. ولما بتزهقوا قولوا لي بوقف.
لا 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 ما بنزهق.
طيب.
ان شاء الله.
Scaphoid fractures are the most common carpal fractures, and they tend to occur in younger active individuals. They account for 2 to 7% of all fractures. It is the second common fracture following a distal radius fracture. It is 60 to 70% of carpal bone fractures. Scaphoid fractures are not uncommonly missed. You know this, especially on clinical and radiographic examination. لما بيجيك حدا where he fell on the extended wrist at 90, تسأله, how did you land? 90 degrees. You look at the wrist, you palpate, there's no deformity. But there is the anatomical snuff box, which lies between the extensor pollicis longus and the abductor pollicis brevis and the extensor pollicis brevis. There's tenderness. Why? Because the scaphoid lies over there underneath the extensor carpi radialis brevis and longus. And as a people anatomical facts, they will have pain. When you have this, you should become more suspicious of a scaphoid fracture. Another point, you can apply pressure on the thenar eminence over the tubercle, they will have pain. If you apply retrograde pressure on the thumb, they will have pain. So these are certain points which would let you become suspicious. But you take x-rays. You take x-rays in multiple views, which I will be talking about, and you don't see a fracture line. You should not hesitate for an MRI or a CT scan in these cases. In the past, we used to do technetium scans to see, and we would detect it. So you have to keep this in mind. The scaphoid is fractured most, and this is the list and incidence of fractures of the carpal bones. You all know that we have 8 carpal bones. You should memorize them. You should be able to speak about them in accordance with your ABC knowledge. يعني بعجلة. Scaphoid, trichitrum, trapezium, hamate, lunate, pisiform, capitate, trapezium. بدك تحكيها بعجلة. The upper extremity. The incidence of fractures of the scaphoid is second to that of fractures of the distal radius. Scaphoid fractures usually result from a fall on the extended wrist. A study in Norway was found that 82% of scaphoid fractures occur in males, with the highest incidence occurring between 20 and 30 years of age. And this is a true statement. I'm telling you this from 50 years or more of experience. It may be misdiagnosed initially as a simple wrist sprain. It leads to increased morbidity for the patient, as the risk of non-union can be high. 14 to 50%. Fractures of the scaphoid have been explained as a failure of bone caused by a compressive or tension referred to the snapped waist. I want you to remember this: snapped waist. إذا بتطلعوا بشيب السكافويد, it's like a C. At the center of the C, on the aspect, you have the concave, and on the opposite side, you have the tension phase. And there is argument. Some say it's due to compression of the concave, while others say it's secondary to tension from being caught between two carpal bones or ligaments. Cobby and White suggested that the scaphoid actually breaks because of compression rather than tension loads, the compression being exerted against its concave surface by the head of the capitate. Hori has also postulated that the mechanism of a fracture is secondary to the concentration of external forces through the second metacarpal. The forces is then and trapezoid, which induce a shear stress at the scaphoid waist. The degree of wrist extension impact is also important. هيدي اللي حكيت عنها, more than 90 fracture occurs in the forearm, distal radius or carpus. Frankman subjected cadaver wrist to static loading, observed that greater extension of the wrist resulted in more distal extension of 35 degrees or less resulted in fractures of forearm. Extension of 90 degrees or more resulted in carpal bone. So don't forget this. This shows you the position and the ligaments in which the scaphoid is locked and how the fracture occurs. The combination of radial deviation and wrist extension beyond 95 degrees tends to lock the scaphoid within the scaphoid fossa. At this point, the palmar ligaments, particularly the radioscaphocapitate ligament, acts as a fulcrum on which the distal pole may flex palmarly, resulting in a waist fracture. Torsion forces may also be considered an important factor in producing this fracture. More proximal fractures are thought to be the result of initial dorsal subluxation of the scaphoid before force supination. The principal vector for scaphoid fractures is extension, whereas the scapholunate injuries tend to occur when ulnar deviation and intercarpal supination occur concomitantly. So think of this. Think of this. The principal vector for scaphoid fractures, we know it's extension. That's one side for the fracture. Whereas scapholunate injuries, we know that there is a scapholunate injury at times accompanying the fracture where we call DISI, and these tend to occur when there is an association with the extension, ulnar deviation, and intercarpal supination occurring at the same time will cause a sharing of the scapholunate junction in the ligament. Concurrent scaphoid fractures and scapholunate tears are uncommon, but must be included in the differential diagnosis. Pain following a fall on the outstretched hand. Axial loading of the wrist with the forced hyperextension and radial deviation can cause the fracture as the scaphoid impacts on the dorsal rim of the radius. Contact sports and road traffic accidents are also common causes. Because of bending moment on the scaphoid, fracture forces tend to produce a compressive force on the volar aspect, volar cortex, and tension on the dorsal cortex. When fractures occur proximal to the waist of the scaphoid, it is a high incidence of displacement because of the opposing forces between the proximal and distal ligament. The persistent flexion force on the distal pole and the extension moment on the proximal pole account for the characteristic humpback deformity. And this is very important, the humpback. What happens is that the distal row of carpal bones through the capitate starts moving proximally. This is seen in chronic scaphoid malunions. Scaphoid fractures are prevalent in young, active people. There is often a strong desire to return to sports or work. Delayed diagnosis and union of the scaphoid are fairly common as well, probably as a result of several factors, including the difficulty of radiographic diagnosis of non-displaced fractures and underestimation of the injury by the patient. Usually patients fall, they have pain, they say, well, nothing, tomorrow it will go. Fracture, wrist pain, he doesn't want to tell his family, his parents. So this is why it's missed. Only when it becomes chronic, many times they come to you. The goal of treatment is intercalated segmental instability. I make it easier, I call it DISI, deformity that may be followed by carpal collapse and eventual osteoarthrosis. The so-called scapholunate advanced collapse or scaphoid non-union advanced collapse wrist. This is what we call it when the capitate moves proximally and you have the scapholunate gone. What we call it either slack when the scaphoid lunate advanced collapse, and scaphoid non-union advanced collapse also cause it. So keep this in mind. Fracture of the scaphoid is usually the result of a fall on the outstretched hand, resulting in hyperextension and ulnar deviation. Injuries that cause forceful extension, sport activities, car accidents may also cause scaphoid fractures. An increase in wrist flexion, that was I read this in a recent article. Wrist flexion is بتلاحظوا boxers where they put their glove and box in flexion, they can have a scaphoid fracture. It occurs in punching game machines. So don't forget it. Even in flexion, it can occur. In these punching games, as in karate or fighting, the wrist is in slight palmar flexion and slight radial deviation. With radial deviation and flex of the scaphoid is impacted between the distal and volar edge of the radius and the trapezium and trapezoid over the radioscaphocapitate ligament. What about the diagnosis? There is some tendency for the diagnosis of fracture of the scaphoid to be delayed because of misdiagnosis, because patients do not see a doctor immediately after injury. Common in children, some of whom may be reluctant to tell their parents about their use of a punching machine or fighting. Scaphoid fractures predominantly affect young adults with a mean age of 29 years. They are unusual in pediatric population and elderly population, where the physis or distal radius, respectively, are more likely to fracture first. Scaphoid fractures account for 15% of acute wrist injuries. A delayed presentation also is common among athletes because of members of the sports clubs or teams do not want to lose their position. The clinical symptoms are not usually severe and may resemble a wrist sprain, something an athlete may have experienced numerous times and may not be particularly concerned about. Many patients with delayed presentations are found to have non-union. I would like to mention at this point is that the scaphoid is surrounded mostly by cartilage. It has no muscle attachment. No muscle attachment. That scaphoid spans two columns, namely the distal carpal bones and the proximal carpal bones. At the site of the interface of these two columns lies the waist of the scaphoid. So you can imagine the amount of stress that can occur in the waist of the scaphoid. It's whole. Another point, that if you have a fracture of the scaphoid, it is totally intra-articular. So what happens? You have synovial fluid around the fracture. This would resolve the hematoma, and you won't have callus formation. Third, you don't have periosteum in the scaphoid, and as a result, non-union is quite high. So, the synovial fluid, the erosion, the destruction. So, forget, and this will tell you why you don't have union. When examining a patient with wrist pain, detecting the tender spot is the most important finding on examination. Tenderness with palpation of the scaphoid radially in the so-called anatomical snuff box. The abductor pollicis longus and extensor pollicis brevis that I spoke about, volarly at the distal end of the scaphoid, and the axial compression of the thumb, all useful palpatory examination maneuvers for scaphoid fracture. I would like to mention that in the synovial fluid, you have plasminogen. The plasminogen dissolves the hematoma. It does not allow a hematoma formation and organize into callus. So this is one of the factors why you get a delay in union and non-union. Another factor, of course, is circulation. Okay, so keep this in mind. This is the anatomical snuff box. You see, you have the abductor pollicis longus and the extensor pollicis brevis in the first compartment. You have the extensor pollicis longus in the third compartment. At the side of the pointer, where it's shown on this photograph, is the two muscles, the extensor carpi, radialis longus and brevis. Beneath it lies the scaphoid. If you apply pressure in this area and they have pain, this would tell you it's a fracture of the scaphoid. Anatomy. Don't forget, the blood supply to the scaphoid is in the superficial, in the dorsal carpal branch of the radial artery, yani on the right-hand side. You see that the vessels go along the dorsal ridge of the scaphoid, okay? So don't forget. By the way, a scaphoid in Greek is known as boat. It's boat-shaped, okay? So don't forget this. Another point is it receives its blood supply through the dorsal carpal branch of the radial artery and the small branch from the palmar branch of the radial artery. So this is it. Proximally, the circulation is poor. Ligamentous attachment, the deep dependent on an interosseous blood supply. The limited vascular supply at the proximal pole is similar to that at the head of the femur. When fracture occurs through the body of the scaphoid or neck of the femur, vascularity of the isolated fragment is jeopardized. Fractures in this location take an average of 6 to 11 weeks longer to heal than those in the middle third and have demonstrated an incidence of avascular necrosis of 14 to any meaningful blood supply enters the scaphoid from the scaphoid. Over the anatomical deformity should suggest a fracture of the scaphoid, and a complete set of radiographs should be obtained. Ya Jamia, you should know what are the complete set. We usually we like the fist view because it brings the scaphoid more in line, and take an AP view I will be talking about them. Let me come. As many as 18 views have been proposed for an exhaustive study of the injured wrist, but only 4 must be included in the initial routine examination. 1 posterior-anterior, 1 lateral, and 2 oblique views. The oblique views are taken for the purpose of trying to identify the fracture site in non-displaced fractures. There are certain centers, as when I was in Toronto, we used to take, we didn't have a CT scan, we didn't have an MRI. For the posterior-anterior study, it is best flexed into a fist, as I was showing you. This produces slight extension and ulnar deviation and places the of the sigmoid in a plane close parallel with that of the film. This will also accentuate, which is important in the differential diagnosis of a scapholunate injury. This is the position that we like to take. As we put the wrist goes into slight ulnar deviation. It's fractured. You can see that there's a fracture through the waist, becomes apparent. And if you have a scapholunate injury, it will become more apparent. This is showing it further, an ulnar deviation forming a wrist. Look at the gap of how it became more apparent between the scaphoid and the lunate. This shows it, the displacement on flex extension. Other imaging techniques have been proposed for detection of suspected fractures, including ultrasound, isotope scanning, carpal box radiographs, trispiral tomography, computed tomography, and magnetic resonance imaging. The multiplicity of approaches highlights the difficulties encountered in evaluating a patient with a suspected scaphoid fracture. This I took from a textbook. It goes to show you these fractures. This is a patient that came to the emergency room in one of the hospitals, had pain in the anatomical snuff box. The resident examined him, said there's nothing. He brought him in 1 week, they said that there is nothing. Did an x-ray after 1 week, 2 weeks, that's it. They asked for an MRI, and look, the patient has fracture. Now, if you look at the x-rays again, you see in B that there is suspicion of a waist fracture. MRI has become increasingly useful in the evaluation of acute and occult fractures. Previously, MRI was primarily used to predict the vascular status of fragment in cases of scaphoid non-unions. Normal marrow elements produce high-intensity signals on T1 weighted images. Avascularity or marrow edema will lead to alterations in Gabler and colleagues performed a prospective blinded study of 32 patients in whom a scaphoid fracture was suspected. MRI was performed at an average of 2.8 days after trauma with sensitivity and specificity of 100%. False positive results have been found in some studies due to MRI sensitivity to marrow edema. Other prospective studies have shown MRI to be more sensitive and specific in the diagnosis of occult scaphoid fractures and soft tissues with wrist injuries when compared with bone scintigraphy. Critical points: evaluation of suspected scaphoid fracture. Number one, obtain a neutral posterior-anterior with addition of radial and ulnar deviation. And don't forget about the clenched fist view if necessary. Perform MRI for clinically suspected cases with radiographs or bone scan at 72 hours from injury. If the MRI or bone scan is negative, no fracture is assumed. If the bone scan is positive but cannot delineate the fracture, one should obtain a CT or MRI. Herbert has devised an alphanumeric classification system that combines fracture, anatomy, stability, and chronicity of injury. Roos classified scaphoid fractures into 3 types according to the relationship of the fracture line to the long axis of the scaphoid. Again, I speak to you about classifications. The one I know is the distal tubercle, the waist, and the proximal pole. But you have to add delayed union and non-union. They have added it with pseudoarthrosis. So be careful. This classification. This is another classification of Roos, which he describes them in 3 types. You have the horizontal type, you have the transverse type, and you have the vertical type. We don't like the vertical type. Why? Because it's not a solid fix. This is the Mayo classification. Distal tubercle, distal articular surface, distal third, middle third, and proximal third. I think this is quite easy to remember. This is the Herbert classification. You need to remember these. This is the Roos classification that I spoke to you about. And you have to be very careful about the scaphoid, which is a boat. You have to pay attention if you get a non-union or a malunion. You know that the proximal scaphoid, if the scapholunate is intact, will move with the lunate, while the distal scaphoid would move distally, being that it's fixed by the surrounding structures. With time, you'll end up having a humpback deformity. Non-displaced fractures are stable and usually heal with a high rate return of function. When a fracture is angulated or displaced, regardless of the direction of the fracture line, the fracture is unstable, will likely require operative management. Study should be suspected in all displaced fractures. Diastasis of the scapholunate interval or lunate extension associated scapholunate lunate instability. Accurate evaluation of displacement, rotation, and stability may be difficult with plain radiographs. Of carpal height can be tip-off to significant fracture angulation, and this is very important. And this occurs with the lunate, non-union, or approximately. You have to pay attention to this, because when the scaphoid shortens, I told you, the scaphoid bypasses both compartments. It maintains length to some extent. When it's fractured and it's collapsing and becoming angulated, this will tell you it has lost certain stability to the area. Questions with regard to fracture displacement may be answered with tomography. CT has the advantage of permitting and reconstruction in various planes, such as the long axis of the scaphoid, even three-dimensional, particularly in chronic non-unions with loss of bony substance. Now, there are certain measurements that we measure, and you have to draw a perpendicular scaphoid, and this angle should be degrees. 40 degrees would tell you the amount of angle if you have a dorsal hump will be done. Just to let you know is that there are measurements that we use that will tell us the amount of degrees with respect to normal. You can do it on both sides of the wrist. And if you see that it's changed, it will let you suspect it. Middle third fractures are the most common fractures of the scaphoid, and like all scaphoid fractures, share a high rate of delayed union and non-union. A delay in treatment, either because of the patient's failure to seek treatment after a seemingly trivial injury, or because of a misdiagnosis, can adversely affect union. Factors include the degree of initial displacement, fracture comminution, and associated carpal instability. A failure to recognize concomitant carpal instability may lead to a high rate of complications of treatment. Gross fracture malalignment or scapholunate dissociation leads to a loss of scaphoid support for the proximal and distal carpal rows and distorts load-bearing characteristics. Most frequently, the lunate becomes extended and the carpus collapses into a concertina or dorsal intercalated segmental instability deformity. I hope you understand this, and this is very important. I would like to mention gross fracture malalignment or scapholunate dissociations leads to loss of scaphoid support for the proximal and distorts load-bearing characteristics. Why did this occur? Why? Because the scaphoid bypasses both carpal rows. So this would lead to loss of support because we lost the scapholunate ligament. Most frequently, the lunate becomes extended. Why? Because It is not controlled by the scaphoid, and it will become extended easily. When the lunate becomes extended, what happens? The carpus collapses into a concertina or dorsal intercalated segmental instability deformity. These are the Galula lines. You have to know these lines. You have to know how normal they are and use the other extremity for comparison. For non-operative treatment to be successful, immobilization must remain effective until union of the fracture. It is important to allow the hand to function because this seems to enhance the healing potential and reduce atrophy. Fiberglass, now the present standard of cast immobilization, is more durable and remains snug for a long time. It's true. This is very true. Let me tell you, in the past we used to use plaster of Paris in these fractures. The patient never listened. He breaks the cast, etc. Then we began to use fiberglass. The fiberglass, you cannot mold it as much as with plaster of Paris, but it's not destroyed. It remains for a much longer time. And this is what I'm trying to stress. Experimental data based on Squire's concepts of mechanics support immobilization of even problem fractures of the scaphoid involving the proximal pole displaced or non-united, with the risk in full ulnar deviation and some extension and the forearm supinated. Ulnar deviation and extension tighten the radial side of the wrist ligaments, supporting the scaphoid between the trapezium and the radius. Supination is believed to shift the lunate radially and support the scaphoid. Against the duration of immobilization for scaphoid waist fractures was rather brief in the early reports. As experience accumulated, it became clear that longer periods of immobilization produced higher rates of union. Assessment of union is impossible by physical examination alone. Reliance on radiographs alone unreliable. This has shown that intra-observer and inter-observer reliability in evaluating union at 12 in a prospective randomized study with 12-year follow-up of comparing early open operative treatment and cast immobilization. Saidin found that the return to work was quicker in manual laborers treated with operation. There were, however, no significant differences in the long-term functional results between the two groups. At operation, you can use an arthroscope and do it percutaneously. This is a technique which requires experience and a continuous teaching, learning program where you control the reduction within arthroscope and you put your screw. Nowadays, we have the cannulated screws and you can put it easily. I just want to mention over here. Now, nowadays, even in the family displays, more than 1 millimeter, 1 millimeter. And what you do is you use the Russ approach, which is a Henry approach. You expose the waist of the scaphoid. You remove a bit from the trapezium. You put your guide wire through the scaphoid. Buried in the scaphoid. Many times you cannot remove the screw even if you want to after 1 or 2 years. So keep this in mind. In general, most non-displaced fractures of the scaphoid will heal if immobilized. Percutaneous screw placement can be associated with technical problems. Inexperience and even in experienced hands, wires may break and the margin for error is small. Exposed threads within the radiocarpal or midcarpal joint would certainly lead to arthritis. With the advent of cannulated screw systems, which can be used percutaneously under arthroscopic or fluoroscopic control, there is a more aggressive tendency in performing operative reduction for fractures with any signs of instability. In general, the indications for casting are non-displaced waist fractures. Distal pole fractures, in general, do have a good position. Now, what about the operations? Acute fractures with displacement, angulation, or carpal malalignment should be treated with open reduction and internal fixation. Multiple methods of internal fixation have been described, including Kirschner wire, compression, screw, staple fixation, and even plate fixation. Unless comminuted or comminution is present, bone grafts are not necessary for acute fractures. This is the Herbert screw. It's a cannulated screw. It is threaded at both ends. It should be buried completely, but as you're burying, it should compress the fracture. This should not be long at both ends, because this would lead to degenerative arthritis. Treatment of proximal third scaphoid fractures and vascularity of the fragment and the age of the fracture. Fresh injuries may heal after prolonged immobilization, although the peculiar blood supply to the scaphoid renders these fractures particularly vulnerable to avascular necrosis and non-union. There is a growing sentiment that most proximal pole fractures should be treated operatively because of their high propensity for non-union and increased duration of immobilization. It's required for non-operative management. Modern techniques of internal and percutaneous increased healing rates and tipped the scale in favor of early operative treatment for these injuries, particularly for the young and active. Reiling and Raskin also use the dorsal approach and a Herbich compression screw acutely on 17 proximal pole fractures and obtained 100 is too small, Kirschner wires can be used. After the union is solid, the Kirschner wires or staples should be removed, while screws can generally be left in place. Ya Jama'a, this is a very easy. You need fluoroscopy. You should flex the wrist posterior approach and exposing the scaphoid bone. When you flex the wrist, the scaphoid becomes in line, and you can easily put your guide wire by your screw. I will advise you to open today YouTube. It has a special approach in percutaneous screwing of the scaphoid under fluoroscopy. Up, and you'll never forget how to do it. Okay, now this is shown easily done by putting this cannulated screw in. Fractures of the scaphoid distal pole are infrequent. They may be limited to the entire distal third of bone. Prosser and associates reviewed 37 cases of scaphoid distal pole fractures and proposed a classification in the three groups, which you are not responsible. Type 1 tuberosity fractures, type 2 distal intra-articular, and 3 osteochondral fracture. But if you want, you look it and know it. Russ's classification fractures distal third were commonly of the transverse stable type, and in his experience, united rapidly, usually after 4 to 8 weeks, in a short arm thumb spica cast. Fractures of the tuberosity and usually stable with a generous blood supply. Non-union of the scaphoid. Non-unions of the scaphoid are treated by surgical means. Previous reports suggested that establishment unions, particularly if stable and without carpal collapse, may not require treatment because they might remain essentially symptom-free. However, it has become clear growing number of publications that ununited fractures or fracture malunions, if left untreated, will progress to osteoarthritis and impaired wrist motion. Published studies concerning the natural history of the scaphoid non-union may be flawed because they are retrospective and not population-based. It is possible that their findings simply reflect selection or referral bias. Nonetheless, it is logical to assume that the severity of osteoarthritis and the rapidity of its progression are greater for displaced fractures in the presence of coexistent carpal injury. New non-unions remain stable, undisplaced, or free of arthritis after 10 years. Long-standing scaphoid non-union leads to a pattern of described by Watson and Ballet. It is described into 4 stages. And you have to think of it. When you get non-union, when you operate, I use the Russ approach and I correct the area and then pack it within autograft, an iliac autograft. This shows you of how we put it. This is the Fernandez technique, but Russ does it. You have to realize of how this is done. These are the screws. It shows you the most important is the graft. Okay? Avascular necrosis factor that renders the scaphoid fracture resistant to healing with both non-operative and operative methods. Proximal pole vascularity cannot be determined from plain radiographs because increased radiographic density of the proximal fragment correlates poorly with the presence of the avascular necrosis. Trumbull has shown that MRI appearance is a more reliable indicator of avascular necrosis. Green recommended directly scrutiny of the fracture surfaces and punctate bleeding. يعني لما بتفوت على الفراكشر and then you see if there's no bleeding and the color of the marrow is yellow, then this tells you it's avascular necrosis. Thank you. I'll take a 5-minute break. عم بلاقي انه يا عم بيزيدوا شوي يا عم بينقصوا candidates. بقى كلهم عم بيحضروا.
يعني شوف كلهم حاضرين والبقية مسافرين او على سفر عبر زوم يعني.
بعرف بس انا بدي اعرف اذا عم بزهقهم او لا.
لا مرتاحين جدا يعني مبسوطين معك بالعكس هم بيشوفوا معلومات كونسايز وهم اللي بيحصلوها بعدين يعني ان شاء الله بحصل اللي بيقدموا الامتحان.
يعني
ايوه نسمعك.
يلا
نسمعك.
هلا رح تقشعوا in calcaneal fractures there's going to be several repetitions, and the reason why I'm repeating is that there are certain points you should never forget. I'll tell you, I've been responsible for the examination board since 1985 till 4 years ago. Yani, it was around 2017. In every year, there was a calcaneal fracture as possible for you to have in the oral. 4 years, I have seen it on 2 occasions in the examination. For this reason, I'm going to repeat my discussion a few times so that it will stick in your mind. The calcaneus becomes wider. And when it spreads as a chronic affair, it will impinge on the lateral malleolus. It will impinge on the peroneal tendons. And the patient in the chronic phase will come to you complaining of pain. Now, you know that the calcaneus consists of several articulations. One of the articulations, which is the major articulation, is with the talus. You have three facets, the anterior, the middle, and the posterior, which is the major facet. Also, you have a connection with the calcaneocuboid joint. And in many times, this is involved in the fracture. We call it the nutcracker fracture if it's compressed. And you see that the heel is shortened. You lose Bohler's angle, which I will be discussing. And the heel could come into varus and widened. What about the classification of calcaneal fractures? Nowadays, we believe in the Sanders classification. It's based on coronal, I repeat, on what basis is Sanders classification? You should say it's based on coronal CT image of the posterior facet. A non-displaced facet of the posterior facet is 1. A single fracture line in the posterior facet is 2. A 2 fracture lines with 3 post-facet involvement is 3 and 3. So in other words, it depends on the lines of the fracture. Look at the slide on the right-hand side. You see a Sanders 3. You see that there are 3 fracture lines. And as a result, we call it a Sanders 3. A Sanders is non-displaced. It's 1. If you have a single fracture line in the posterior facet, it's 2. If you have 2 fracture lines with 3 posterior facets, it's 2. 3 fracture lines with 4 plus fragments is 4. So you have to realize this. This was done by Sanders. There was another one, which is that Essex-Lopresti one, where you have a extra-articular and intra-articular fractures. The extra-articular were tongue-like fractures through the body of the calcaneus, while the intra-articular were depressed fractures. So it's up to you. You should have an idea, if asked, about the classification of these fractures. So the treatment is non-operative, non-displaced fractures. Of course, we all agree with you. Extra-articular fractures, 25%. VS cast boot, early range of motion. Closed reduction cannot restore articular congruity. You have to realize this. So the treatment of calcaneal fractures, there is much controversy. You have to think about the surgical approach, which is the longitudinal L incision done on the lateral aspect of the foot, which we will be talking about. The cerebral nerve in this case. The type of implants, the bone graft that you use, you should pack the void space. Otherwise, the deformity will recur. And the post-operative treatment and the results of superior if operated to non-operative treatment. The treatment, the operative trend is towards surgical intervention. We prefer surgery if you have a total distortion. of the intra-articular component, and you've lost Bohlet's angle, and you've lost the intra-articular angle that we will be speaking about soon. So we should restore the calcaneal anatomy and reduce the articular. Now, you should make the body of the calcaneus narrow so that it won't impinge on the lateral malleolus. You can use either medial or lateral or combined approaches. Extensile lateral are most popular. Low profile implants are requested. Wound complications occur in 10 to 20% risk, are high in smokers and diabetes. Longitudinal incision. The peroneal tendons lie. What you should do, you should undermine the peroneal tendons, raise them with a Homan retractor, insert 2 pins to maintain a continuous retraction and minimal damage to the flap. Pay attention in this approach to the sural nerve, both posteriorly and anteriorly. The complications of calcaneal fractures can be compartment syndrome in 10%, heel deformities, of course, you know, because the heel moves proximally by the pull of the triceps tendon. And heel deformities and malunion, you can end up having subtalar arthrosis. Factors associated with poor outcome are the age greater than 50, obesity, manual labor, and workman's compensation. The calcaneal fractures are the most common fracture of tarsal bones, and it represents 1 to 2% of all fractures. You have to realize that deforming force, and one of the major deforming force is the Achilles tendon, which is the biggest and largest and strongest tendon inserted on the calcaneus. Of these fractures, roughly 75% are intra-articular in the posterior facet. I repeat, in the posterior facet of the calcaneus. يعني إذا حدا سأل which facet? We have 3 facets. We have the anterior, middle, and posterior. Where is it mainly? You should mention posterior facet of the calcaneus, devastating injuries. 2, the lower extremity usually occur as a result of high energy trauma from falls or motor vehicle accidents causing axial loading. These fractures are often challenging and difficult to do, and health outcomes have been found to be comparable to myocardial infarction and chronic renal disease. This is what we compare. We have difficulties in orthopedics. Whenever I get a calcaneal fracture, which is intra-articular and comminuted, I say, why did I become an orthopedic surgeon? Many challenges arise for the surgeons because of early and late complications associated with intra articular calcaneal fractures. And the optimal management of these fractures has been widely debated in the literature. The calcaneus is the largest of the tarsal bones and has 4 articular surfaces. We spoke about the posterior, the middle, and the anterior facets, whereas the articular surface with the cuboid is found distally. Medially, the sustentaculum tali supports the middle facet and provides a groove for the flexor hallucis longus tendon inferiorly. This shows you the calcaneus when you're looking from above. You can see the anterior facet, you can see the middle facet, you can see the posterior facet. You look at the proximal end. This is the area where the Achilles tendon is inserted. And this is the largest tarsal bone. The tuberosity, where I spoke about, where the Achilles tendon is inserted, is round on the posterior surface of the calcaneus. And you have the peroneal tubercle is found on the lateral surface beneath longus tendon passes. The tubercle supports the peroneus longus and brevis and prevents it. It allows it to lie within a tunnel. The anterior process of the calcaneus is located on the most distal and serves as the origin for the bifurcate ligament, which inserts on both the cuboid and the navicular. So it is through the anterior process that the bifurcate ligament catches the navicular and the cuboid. Now I'll go into more detail. This is the peroneal tubercle. Underneath it, or in this region, is the peroneus longus, peroneus brevis. Okay? There is a tunnel over here, we call it the tubercle sheath, either inferior or superior, which can rupture, and it would lead to pain and recurrent subluxation, and one would have to repair it. At the inferior end, you have the lateral process and the medial process. Okay? So this is which gives you the bifurcate ligament, which attaches to the navicular and the cuboid. This is the anterior facet. You have the middle facet. You have the posterior facet. So please remember these. When viewing the calcaneus on a lateral radiograph, there are 2 angles of clinical significance. I'm going to go up again to the previous. You see that there are 2 angles, one pointing towards the medial facet and the other one pointing towards the cuboid. So this is cuboid and the other one be the facet. So these are 2 angulations. So keep this in mind. Now, on lateral radiograph, there are 2 angles of clinic, and on radiography, we can have also 2 angles. One, the Bahla angle or the tuber angle. And this is measured by drawing 2 lines, one from the highest point of the anterior process to the highest point of the posterior facet, and from the highest point of the posterior facet through the highest point of the tuberosity. I'll show it to you. These are the two lines. This is, C is the anterior facet, the anterior process, calcaneal process, which has the bifurcate ligament that attaches to the cuboid and the lunate. Then over in B, you have the posterior facet, the highest point. You draw a line, and then the highest point of the tubercle is over here, and the highest point still of the posterior facet, you draw a line. This should be 20 to 40 degrees. If it is less, it means that the fracture is the whole body of the calcaneus is moved proximally. This is known as the tuber angle or the Bahla angle. The intersection of the two lines at the superior portion of the posterior facet creates the angle. A normal Bahla angle is between 25 and 40 degrees, and decreased values as the posterior facet collapse inferiorly. You can see it over here. They collapse, therefore the Bahla angle becomes less. The Gazin angle, which is known as the critical angle, is measured at the intersection of a line drawn along the posterior subcaudal bone of the posterior facet and a line drawn from the anterior process of the calcaneus down to the inferior portion of the posterior facet. A normal Gazin angle is between 120 and 145 degrees, and this angle may be increased or decreased with intra-articular fractures depending on the position of the foot and direction of force at the time of injury. This is the Gazin angle. Okay? This is the lowest point, the angle, the anterior process, and you have the posterior facet. This is between 120 and 130 degrees. This is the critical angle of Gazin. If these are destroyed, this angle will change. It will in intra-articular fractures. In Bahla's angle, you lose this angle. So you have to pay attention to this. Although reliability and utility in diagnosis are excellent using Bahla angle, the Gazin angle has been found to lack sufficient sensitivity, specificity, and inter-rated reliability to be used for the diagnosis in emergency department settings. The addition of to lateral radiographs, I have this black thing in my way. The addition to lateral radiographs, the Harris projection is used, which is an axial heel radiograph tilted 45 degrees caudally with respect to long axis of the foot. This view allows for evaluation of the subtalar joint displacement, heel widening, and valves. I'll tell you, the Harris views, we used to use them in the past. Why? Because we didn't have CT scans. And it would tell us a lot about the facets between the talus and the calcaneus. We used to do the Harris view on the multiple angles with the tube posterior to the heel would tell us how wide the calcaneus has become following the fracture. And it would tell us or give us an opinion on the facets, what's going on. This is the Harris view. You see, we were not very lucky at my time. We could get the maximum of subtalar joint surface, but not enough, as you will get with the CT scan. That a good view of the subtalar joint, loss of height, increase in width, angulation of the tuberosity. Intra-articular calcaneal fractures involve a primary fracture line running through the posterior facet, forming a superior medial fragment and superolateral fragment. So the fracture line is running through the posterior facet. You have to keep this in mind. Okay. And by running, it separates fragments. The superomedial fragment is described as the constant fragment, as it is fixed by the deltoid and interosseous talocalcaneal ligaments. Although several classification systems exist, these fractures are most often described using the Sanders and Essex Lopresti classification system. The Sanders classification system fracture patterns are classified based on the number of fracture lines through the posterior facet seen on semi-coronal CT image at the widest portion of the talus. Type 1, type 2, type 3, we spoke about them. And you have to realize the number of fracture lines as to be able to classify them according to the Sanders classification. These are them. Okay, so the CT scan will help us a lot in classifying. Okay, now I just want to, the Essex Lopresti classification system uses planes of the primary and secondary fracture lines in order to classify the fracture pattern. The primary fracture line always occurs through the posterior facet, creating two fragments. The secondary fracture line either occurs in the axial plane or behind the posterior facet, creating two unique fracture patterns. The first, the joint depression type of fracture, occurs when the secondary fracture line extends across the body of the calcaneus posterior facet is formed and depressed. These show you the classification of Essex Lopresti. One is an intra-articular fracture. The other is an extra-articular fracture. The lateral view of the right foot depicts in 8, you have a joint depression. This is an intra-articular fracture. In B, you have a tongue-type fracture. Axial load through the subtalar joint leads to depression of the posterior facet. Tension from the Achilles tendon leads to posterior-superior displacement of the tuberosity. A classic radiographic findings of the joint depression type of fracture include decreased Bohla angle, decreased Gazin angle, calcaneal shortening, calcaneal wide deformity. The second fracture pattern, the tongue type of fracture, occurs less commonly and is described as a secondary fracture line running posteriorly underneath the facet to tuberosity in the axial plane, and this shows it. Okay, so don't forget this. These various classifications, which I hate. These fractures are associated with posterior-superior displacement of the tuberosity due to, in part, result. These fractures may lead to skin tenting of the posterior heel with risk of subsequent pressure necrosis and thus can require urgent operative management. Serial physical examinations should be performed in patients with tongue type of fractures to identify blanching and other signs of skin breakdown over the fracture site. Operation vs. non-operation. There is some debate between conservative vs. surgical management of intra-articular calcaneal fractures because of variable results between the two management strategies. Regardless of management strategies, all patients present with calcaneal fractures should be evaluated for associated injuries. For instance, if one is falling from the height and has a calcaneus fracture, you should look at the knee, the acetabulum, and associated injuries. This may require radiographs or advanced imaging modalities and should be performed on a case-by-case basis. Complications associated with calcaneal fractures include compartment syndrome, fracture blisters, skin tenting with wound necrosis, and sural nerve pathology, tarsal tunnel syndrome, peroneal tendon subluxation, subtalar and calcaneocuboid arthritis and malunion. Non-operative management, I'll tell you it repeatedly. First of all, you should pay attention and rule out a compartment syndrome, rule out associated injuries of the calcaneus. You start with a posterior splint, followed later on, once the swelling subsides, by a cast and a heel. We encourage patients to bear weight earlier. Now, if we have a tongue fracture with the Achilles tendon pushing it or pulling it proximally, we usually put the Gazin spike against the fragments, the open tongue, into place. Some put screws to hold it better. At times, you would find that Achilles tendon is so patients with operative fracture patterns, but who have comorbid conditions such as smoking history, poorly controlled diabetes, severe peripheral vascular disease, or low functional status may also be managed non-operatively. Additionally, patients with life-threatening envelopes secondary to fracture blisters, trauma, and edema may be considered for initial non-operative management with follow-up management of fracture. Malunion, subtalar arthrodesis are although advanced age may be another relative contraindication. For all types of surgery, acceptable outcomes after surgical treatment of intra-articular calcaneal fractures have been demonstrated in patients older than 65 years, and a retrospective review of 175 patients treated surgically found no difference in clinical outcomes based on the age group. The potential disadvantages of non-operative management include inability to anatomically reduce the posterior facet, decreased functional recovery, increased rates of subtalar and calcaneocuboid arthritis, risk for malunion, and increased rates of subtalar arthrodesis. What we're doing, we're not reducing it. So all the deformities that you have at the time of the injury would remain if you do a non-operative method. What about the operative management? Operative management is generally indicated with open fractures, tongue-type fractures that put the soft tissue at risk for breakdown and displaced greater than 2 millimeters. Intra-articular calcaneal fractures, where an anatomic joint restoration in a proper surgical candidate. Again, the overlying soft tissue will dictate much of the surgical decision making, and the authors recommend that surgery be postponed until the soft tissue envelope demonstrates wrinkling, resolution of the fracture blisters, and swelling, and other signs that portend good wound healing. The optimal surgical approach for displaced intra-articular fractures includes Sanders type 2, 3, and 4 fractures, the joint depression type fracture, and the tongue type fractures. Depends on the surgeon's comfort with the different methods, the patient's comorbidities, and fracture soft tissue characteristics. Randomized controlled trials, multiple randomized prospective clinical trials have been performed evaluating the outcomes of operative vs non-operative management of displaced intra-articular calcaneal fractures with quite variable results. Soderson published the first randomized clinical trial in 1996 evaluating operative and non-operative management of intra-articular calcaneal fractures. In this study, patients with either Sanders 2 and 3 patients were randomized to either non-operative or operative. In L-shaped extensile lateral approach, the authors were able to demonstrate significant difference in the American Orthopedic Foot and Ankle Hind Foot Functional Outcome Scale for operatively treated patients was 86.7 vs 55 only for non-operative. That, in other words, the operation gave us better results. So the study was limited to a few number of patients, especially if there's total intra-articular involvement with depression, especially when there's a tongue type where the Achilles tendon has shortened. These are all important points. So I want to mention over here The surgical approaches we use, although there is a continuous debate surrounding operative vs non-operative management of these fractures, novel surgical approaches and techniques have been developed over the last few decades in an attempt to better avoid soft tissue complications and more. And what we're doing nowadays is I'm going to shift because I'm going to tell you we're using lateral approach. This is an A. When we want to minimize it, we can use the sinus star. Extensile approach is what I use mainly in the patients. The incision is below the peroneus longus and brevis tendon. I elevate them and then I'm directly in the subtalar joint. We don't like to strip the flaps. Okay, so because this is an avascular zone, you have to pay attention to the sural nerves, and it gives you a clear view of the subtalar joint. The time when to operate is the wrinkled sign, where the skin shrinks. It tells you the edema has subsided and tells you go ahead and operate. There is another medial approach, but you don't get both approaches. Be careful from wound complications and infections. This medial approach has historically been used with a 5-centimeter incision parallel to the sole of the foot, made just posterior to the neurovascular bundle. The proposed benefits of this approach were decreased wound and infectious complications and decreased time and non-weight bearing. This approach, I have to get this black out. This approach has fallen out of favor. I don't know why this today's my way. However, in part because direct visualization of the subtalar joint is not provided. Moreover, 2 prospective studies attempting to achieve fixation through the medial approach ultimately used an additional lateral incision in 20 and 57% of cases, respectively. The limited incision, the sinus tarsi approach, the limited incision tarsi approach employs a 2 to 4 centimeters from the tip of the lateral malleolus. I've shown it on a previous slide. It's a mini approach, but you need to extend it if this is the mini approach, limited incision sinus tarsi. This is the L approach. It's an extensile approach. This shows you the approach. This shows you the peroneus tendons. You see, there are 2 Steinman pins shown over here. This is not very apparent. It provides a constant, limited amount of retraction of the peroneal tendons and the flap. This decreases, which you can see the subtalar joint, and everything's under your surface. I'll tell you what I have learned from some European surgeons, that when you operate, you should remove a square of cortical bone from the lateral aspect of the calcaneus. By doing this, you can see directly all the fragments that have depressed. Then you bring a curette which is large and use the opposite side. You elevate these. You obtain cancellous bone. You pack it with autograft. If you don't have enough, you get allograft, a femoral packet with it. Now, if you have shortening of the calcaneus, I have used distraction. I've put pins in the body of the calcaneus and pins in the metatarsal and distracted, so as to be able to get these fragments out of place. And then I gradually remove the traction, decrease it, and then I apply my plate after having putting the block of bone that I removed back in place and the plate over it. Believe me, it works quite easily and it gives you a good radiologic end when you want to show it in staff meetings, showing that you have done a good job. Plate and screw constructs are most often used in combination with this approach. There are multiple theoretical benefits of this approach. First, decreased manipulation of wound and infectious complication rates. This shows you a special plate where bone graft was put and square was removed from the calcaneum and packed with bone to regain the subtalar joints. If you notice that the calcaneus is down to level, if you draw the Bahler's angle, you will find that it is back to around 30 to 40 degrees. Even the Gazin angle is good in this case. So you have to keep this in mind. Second, this approach reduces the need for peroneal dissection and likely resultant irritation and or subluxation. Because I told you, you put 2 pins in the talus to hold it up continuously. Last, the approach allows for easy conversion to traditional ELA or extended lateral approaches should there be a need intraoperatively for in future scenarios. Now, I've got this black thing came in my way. Again, you can continuously use the mini-invasive approaches. Now, we don't deny that infection is our great problem, around 2.1%. Nevertheless, infections do occur after these procedures and must be watched for. Individual studies evaluate skin and for superficial infection rates of up to 14%. Additionally, these techniques may not allow adequate fracture visualization and manipulation. So let me see what I have to say, and I'll make a resume. Okay. What is pulling this portion of the fragment proximally is the Achilles tendon. The subtalar joint is normal. So in this case, you should bring down the calcaneus percutaneously and insert screws. At times, you won't be able to bring it down because the and then you'll be able to bring it down. And you can see that Bartlett's angle is back to normal. Okay, this is in other case, which is intra-articular through the facet. And in this case, likewise, it was brought down, the facet was redone, and 2 cannulated screws were installed. So percutaneous fixation helps in these fractures. You can also use K-wires, but they should be removed later on. This is a patient who had a fracture which was comminuted following a fall, and you see that Bartlett's angle is down to 10. You see that the Gazine angle is completely distorted in this fracture, and you see that the anterior process is left alone due to its bifurcate ligament, which attaches and the cuboid. The patient, through multiple small incisions, one study noted that only 52% of patients who underwent distraction and percutaneous fixation for joint depression type fractures had good to excellent outcomes, whereas 100%, which is normal, of tongue type fractures treated with this technique had good to excellent. Well, because we had control of the fracture. In intra-articular fractures, it's very difficult to do. What we do, how we do it, we put a chance screw and we apply our plate, which is non-invasive, and put our screws. This is a case done percutaneously, but I'll tell you, in the past, I've done so many pin fixations, which we used to use to leave it out and incorporate with the bottom plant of flexion and the outer end of the pin being. So you have to do this and keep it in mind. So don't forget, we classify it, the Sanders classification. You have to keep in mind, you have to always realize what is going on, okay? So this is for the fractures of the calcaneus. You have to pay attention to the sural nerve because at both ends, you can injure it. These are the type 4 fractures of Sanders, where a chance screw is being applied, you apply distraction, and you elevate the fragments, and you apply your plates. Many use arthroscopic assisted reduction, and I have no experience in it, but this is used. In summary, intra-articular calcaneal fractures are morbid injuries with well-documented complications associated with both operative and non-operative management strategies. Their Saunders type 1 fractures are best managed non-operatively, and that Sanders type 4 fractures should be managed operatively with open reduction and internal fixation fusion in the appropriate patient. Any open fracture that places the soft tissue envelope at risk for necrosis, like tongue type surgical management. The optimal management of other fracture patterns within the Saunders and the Essex low-prosty classification schemes, however, remains a topic of debate. Operative management appears to be beneficial in patients where anatomic restoration is possible, and recent literature has focused on minimally invasive management in comparison to non-operative treatment. The surgical advancement in approaches have allowed for decreased wound and infectious complications in operative treatment of intra-articular calcaneal fractures without compromise of patients' outcomes. At this time, however, further studies are needed to clarify this. Now we come to another topic, but before I come to that, I want to make a resume in my way. The calcaneus is the largest tarsal bone of the foot. It bears the load of the individual when they fall from a height, or if they're in a motor vehicle accident. When the force comes on the calcaneus, it can injure your tibial plateaus, it can injure your acetabulum, or have a compression fracture of the vertebral body. You have to think of the associated injuries from this fall. Now, there are extra-articular and intra-articular injuries, and these involve mainly the posterior facet. You have to know that there's an anterior, middle, and posterior facet. The posterior facet is the larger facet. Okay. Now, you have to know that there is another facet with the cuboid bone. You have to know that the anterior process has a bifurcate ligament that inserts on the navicular and cuboid. It holds them together. You have to know that there's a tubercle, and underneath it are the peroneus longus and brevis. This is very important because when you undermine them to remove them from the outer surface, you can put 2 pins in the talus. So keep this in mind, please. Now, you have to know that there are in our classifications the standard as a permanent position, and the number of lines laterally it adds to the classification from 1, 2, 3, and 4. And this will give you a CT classification of these fractures. Harris, in the past, did not have a CT, so he used tangential views, which are taken from the posterior aspect of the calcaneus to facets. You have to know when you have a fracture, the body of the calcaneus widens. It impinges on the peroneal tendon and the lateral malleolus, and they would have symptoms. Another point is with these intra-articular fractures, you end up having degeneration, and as a result, you might end up doing either scalar arthrodesis or triple arthrodesis. So these are points you have to remember. Don't forget that the Achilles tendon can pull on the tongue, irritate the skin, you get sloughing of the skin, and this is an indication for surgery. Don't forget that you should remove a square and then pack it with bone. You don't forget that you have to make use of a shank screw for traction so as to get the body out of the way. The body shortens, the fragments become localized, and you cannot get them into place unless you apply traction. So keep this in mind. Okay, pelvic fractures. I'm going to go very quickly, I'm sorry. Now, most fractures occur in young adults involved in high energy accidents, such as motor vehicle accidents or falls from a height. Pelvic fractures are often associated with other life-threatening injuries. A smaller percentage of fractures occur in older patients with osteoporosis who sustain lower energy injuries, most commonly from a fall from a standing height. Patients with osteoporosis are also prone to insufficiency fractures of the pelvis. The pelvis is formed by two innominate bones, and in between you have the sacrum. Each innominate bone is formed by three ossification centers: the ilium, the pubis, and the ischium. The anterior portion of the pelvis ring is joined by ligaments, and this is known as the symphysis pubis. So this is what we're seeing. We're looking at the sacrum lying in between both innominate bones. There are anterior sacroiliac ligaments and posterior sacroiliac ligaments. You have the sacrospinous and sacrotuberous ligaments. These are all important ligaments. The posterior pelvic ligaments join the sacrum to the innominate bones and include, as I mentioned, the sacrospinous and tuberous ligaments. You have the anterior and posterior sacroiliac ligaments. These are some of the strongest ligaments in the body and take considerable force to disrupt. The iliolumbar ligaments connect the ilium to L5 transverse process. The sciatic nerve is formed from the lumbosacral plexus and includes the roots of L4, 5, S1, and S2 and S3. The L5 nerve root runs over the sacral alae, approximately 2 centimeters medial to the sacroiliac joint. And this L5 nerve root could be damaged when we operate on them. The sciatic nerve exits the pelvis through the greater sciatic notch and typically runs deep to the piriformis muscle and then superficial to the remaining external rotators. You have to know the anatomy, the common iliac artery, of how it gives the external and internal iliac arteries. You have to know about the femoral artery. This is the anatomic distribution of arterial blood supply. You have to memorize these. You have to know where is the profunda artery, where is the obturator artery. All these are important. Okay, and the inferior gluteal artery, the gluteus maximus muscle, and internal pudendal artery, the obturator artery. So these, you have to know them. This is what I'm trying to tell you. The surgical approaches, when performing an anterior approach to the sacroiliac joint, it is important to carefully dissect over the joint to avoid injury to L5 root. When performed a posterior kosher line and back, you have to pay attention to the sciatic nerve. And the external rotators, with the exception of the piriformis, can be placed between the retractors and the nerve to provide some protection. Know where the obturator artery is. Know where the superior gluteal artery and what does it supply. Know what the columna mortis is, which if you cut it, you might not be able to be tie it, and as a result, the patient will start bleeding. You should look for pelvic stability. What is pelvic stability? We know that pelvic stability can occur both in rotation and vertical planes. It depends on which ligament is cut. If you have the sacrospinous ligament cut, it's a rotation. If you have a sacrotuberous, it's a vertical. And the anterior sacroiliac ligament are important together with the posterior. So you have to keep these in mind. So we have strong ligamentous structures. The pelvis, we call it a vertebra. It's a connection. It's connected to the transverse process of the lumbar spine, L5. So you have to keep in mind that this is what's happening. We have classification. We have open book injuries. We have closed book injuries. We have Malgania fractures. We have bucket handle fractures. And the man who was an authority on this classification is Marvin Tile. And of course, you have Burgess. The mechanism of injury is a high energy injuries, and this can result in unstable fracture patterns. Fractures resulting from a fall from a height are usually stable and often involve a minimally displaced superior and inferior ramus fracture in front of the pelvis and an impacted sacral fracture in the back. I want to mention at this point, when you have a fractured pelvis, you have so much hemorrhage. Is it from the vessel? Not much. It's usually from the cancellous bone. And you can have a retroperitoneal hematoma. If the bladder, it might be displaced by the blood to one side. So you have to, when you get the fracture of the pelvis, you should look at the hemodynamics status, the bleeding. How is his blood pressure? How is his circulation? How much blood did he lose? Would you give him isotonic solutions? Would you give him O negative blood? And then give him the cross-matched blood? So you should put the patient with a significant pelvic fracture in a binder so as to compress or tamponade the bleeding. Now, if bleeding doesn't stop, then you have to use embolization. And if embolization doesn't stop, the last is to open and pack. There's a high mortality in these significant fractures of the pelvis. Now, there are three main sources of bleeding, as I said. Hemorrhage most often results from venous and osseous bleeding. Venous bleeding can lead to the formation of a large retroperitoneal hematoma, and this bleeding may not be readily apparent on physical examination, but will be seen on CT scan of the pelvis. You have to give them O negative if they don't respond. If you want to do peritoneal lavage in fractures of the pelvis, you should do it above the umbilicus so as not to get a false positive finding. You should pay attention and rule out neurologic injury of the lumbosacral trunk and sciatic nerve. The femoral nerve obturator nerve and pudendal nerve. You have to go into it. In severe fractures, you can have gastrointestinal injury, and you should do a rectal examination, and you might even need to do rigid sigmoidoscopy. Genitourinary injury. If you see blood at the tip of the meatus, you should do a retrograde ureterogram or avoiding cystogram. You should call a urologist to investigate and see, does he have a if you do a rectal exam and you see that the prostate is high up, this will tell you that there's a rupture of the urethra. Be very careful about it. Where does the urethra most commonly rupture? Is it in the bulbous portion? Is it in the membranous? It's in the past, we used to think it's in the membranous. Now we know it's in the bulbous. So don't forget this. You have to take special views in pelvis. You have to take Judet views. You have to do inlet and outlet views and AP of the pelvis. All these are significant. And of course, a CT scan is most important. So this is what we expect, showing the inlet and outlet view and regular AP of the pelvis. This is a CT scan of a patient who has an open book. We don't operate them if they're less than 2. Now about the type classification. Type A is fractures are stable in both rotation and vertical directions. This tells you that the sacroiliac ligaments are present, yani the sacrospinous and sacrotuberous. In type B, the fractures are unstable in rotation, tells you that the sacrospinous ligament is cut and therefore it opens. In type C, it's both, where you have displacement and opening of the pelvis. This is what gives us the Malgania fractures, the bucket handle fractures. So don't forget about these. You have Young-Burgess classification. You have to look it up. This shows you the sacrospinous and the sacrotuberous ligaments. Okay, there are two types of fractures. One is the anterior compression and lateral compression. Lateral force being applied to the pelvis. Vertical shear fractures result from vertically directed force through the pelvis, as in a fall from a height, and are unstable injuries. A fourth type of fracture in Young-Burgess classification involves combination of any two patterns. Okay, treatment is, depending on the fracture, you need to immobilize it. You need to put a screw through the sacroiliac joint, horizontal. Put it under fluoroscopic control. You have to know the anatomy. This is done after reducing the pelvis anteriorly. You cannot expect a pelvis to be reduced anteriorly and forget about the posterior. You won't. You'll get recurrence of the displacement. So what we're doing now is to operate, put plates. We have multiple fractures. We put plates. We immobilize the patient, and that's it. But you have to pay attention to the complications. These patients have a high incidence of thromboembolism. You have to take care of it. Yeah, you know that many of these patients succumb to having shock, which was not responding to treatment. You have to pay attention to this. Many times these fractures are associated with abdominal injuries, pancreatitis, pancreas, intestines, and in women, vaginal cervical trauma. So you have to do a rectal exam on every case. You have to examine the vagina. And in these patients, you might have to do a colostomy so as to translocate the fetal material away from. Now, on having these patients coming to the emergency room, you can insert an external across the pelvis anteriorly and can create anterior inferior iliac spine, and the fixator is brought together to correct the fracture. We used to use pneumatic anti-shock garments. We used to use it. But what we found is that these have been associated with compartment syndromes. So we don't use it that often. Also, in addition, these garments can cause respiratory compromise. Okay, so these you have to keep in mind. So you treat the patient by external fixator, by binders, whatever you can to create a tamponade to stop the bleeding. This is the first emergency. Then later on, you start deciding what permanent treatment you can do. And you can work posteriorly and insert screws. I'm sorry I have to carry on this in a rapid way so that, you know, this is an open book fracture that the plate was put in this patient. And I'll tell you that's what I always do. I put double plating because one plate does not hold very well. In the sacroiliac joint, you can put screws, you can put plates, but you have to pay attention to nerve root. This shows you the plates of how we put them. This is a special way that we're doing. We put pedicle screws through the fifth lumbar vertebra and put them in such a way fracture distally. If you look at the bottom, the right side, you can put two screws away from the joint to bring them in cases of open book fractures. So you have to do rectal, diverting colostomy. Neurologic injury occurs in 10 to 15% of patients with pelvic fracture. Neurologic deficit, CT scans should show us the site of entrapment if there is so in nerve injuries. Use electromyography and pay attention to the genitourinary injury. You should make sure that there's no fragments in the way, because in a 1 month it will close, but you have to insert a folic acid. Let's see. Hypovolemic shock, we spoke about it. Rehabilitation them up to prevent thromboembolic disease in patients where you cannot give them anticoagulants. You have to do in a filter, insert a vena cava filter. Beware of iatrogenic nerve injury and where to put insert screws. You have to know the Letournel and Judet classification of fractures of the acetabulum. This is the classification: anterior wall, posterior wall, transverse fractures. Then behind you have combination fractures. Okay, so anterior wall, posterior wall, and anterior column. You have to know posterior column and transverse fractures. Now, I'll tell you, in acetabular fractures, usually it occurs when a patient's driving and his hip is flexed. You can get a posterior wall fracture. It depends on the position of the hip within the acetabulum when you get an acetabular fracture. These are quite common fractures on the autostrat that we are seeing. And you can get, in this position, you can get a central dislocation of the hip. You can get an anterior column fracture, posterior column fracture combined with posterior wall. You can get transverse fractures. And when you look at classification, you have an idea of these fractures. Now, these fractures, it is preferable not to operate them early. We like to operate them on the second or third day for the same reason as pelvic fractures. Why? Because they will bleed. We believe in tamponade to allow these fractures to heal, and then we operate. Now, the problem is when you have osteoporotic bone and the patient has an insignificant fall and ends up having a fracture. The ischial tuberosity and extends from the greater sciatic notch. You have to know of the anterior column, which involves the innominate bone, the anterior portion of the acetabulum, and the pubis. So pay attention to these. Approaches include the ilioinguinal approach, which is an approach to the anterior column. You have to separate each into 3 portions, and this approach is a good approach, but a meticulous approach. And one should pay attention that there are important structures that you could damage, but you are not going you go in between as you make your incision along the iliopectineal eminence and apply your plate. And you have to go in between to get this. Okay, look, I'm showing you all these. This is an ilioinguinal approach. The stopper approach is a one-half ilioinguinal approach. 3 windows have been described with the ilioinguinal approach. The first, or medial window, lies medial to the external iliac artery and vein, and usually we get it with the spermatic cord. The second, or middle window, lies between the external vessels and iliopsoas muscle. The third, or top window, lies lateral to the iliopsoas. And that's how we get our plate and do also lies deep to the medial window in the ilioinguinal approach. But do it once and you will find that it is not difficult. Okay, not difficult. But you have to know your anatomy and where you are. The advantage of this approach, it has no muscle attachments onto it. And therefore, heterotopic ossification is rare in the ilioinguinal approach. You have the lateral femoral cutaneous nerve could be damaged because it goes along the iliac crest to the anterior spine, the inguinal ligament to the symphysis. This approach is excellent for fixing the anterior column. The obturator are in the medial window. The corona mortis is an anastomotic connection between the external iliac and the obturator artery or vein. If you cut this, it's hectic. You have to serve it. And what happens, it retracts into the pelvis. The coxa Landenbach is used to access the posterior column or posterior wall of the acetabulum. And I tell you, you should be acquainted with it, and I'm sure you are acquainted. This is the coxa Landenbach approach. Okay? This is the extended iliofemoral approach where you can reach both using the posterior wall and column or the anterior wall and anterior column, and it will help in transverse fractures. But in this approach, you're detaching muscles. In the ilioinguinal, you're not detaching muscle because there's no muscle insertion. In this approach, we have a high incidence of heterotopic ossification. Then we have the Watson-Jones approach, which is easy to do. You go in between the tensor fasciae lata and the gluteus medius, and then you have the capsule directly underneath. So don't forget these points, these approaches. The triradiate approach we don't use at all anymore. Okay, but you should know that it exists. The mechanism, I told you, it's a fall from a height or an impaction while driving in the seated position, depending on the position of your knee, if it's in adduction, abduction, flexion, or extension. Don't forget, many times these patients come to you with swelling of the skin and bubbly appearance. You feel the skin and it's moving. Well, this is hematoma underneath the subcutaneous fat, which is causing this. When you're doing an operation, you should not go through this area because you'll get sloughing of the skin. And this is called the Morel-Lavallée lesion. You should pay attention to the sciatic nerve. It can become locked in between fragments. And you should examine your patient well prior to any surgery following the treatment. Yani, you first build up the blood pressure, immobilize the fractures clinically by either external fixators, by binders, or whatsoever, and then examine your patient well. You have to take the radiographic views, the AP, the Jode views, which are 45 degrees internal and external views, and pelvic inlet and outlet views. These are important. Of course, you need the CT scan. This is the ilioperitoneal approach or the Jode view. I want to tell you this. if you're taking an X-ray and you see the obturator forehead, then this is known as an obturator view. Now, I would like to take advantage. You see these multiple arrows. This is and we do it. We expose the superior pubic ramus and the anterior portion of the ilium through windows to put our plate. We can very easily put our plate proximally, but we cannot put it distally. So we have to put Penrose drains on the three structures that I spoke, elevated, and pass our plates beneath it. Now, the other view, which is the iliac view, or Jode view, is you see the innominate bone clear completely. So you have to pay attention. Okay, and you have to be able to find the acetabular wall, anterior, posterior, etc. So and the anterior wall. The obturator oblique view better demonstrates defines, particularly in identifying the location and displacement of fractures and loose fragments in the hip joint. CT also helps in preoperative planning. And when you're operating on these patients, you have to look at the margin of the fractures. Many times you get fragments impacted in. You have to disimpact them to create a smooth particular surface. Another important point that you should keep in mind is that CT helps us in that. It's very important. The minimum displacement of not more than 2 millimeters. We like to obtain this. And when we're putting our plates in, we have to know where we are putting the screws. At times, you can get a screw within the acetabulum. To prevent this and fall, you should sterilize a stethoscope. That's what we do. And we put this sterile stethoscope on our ears with support of a nursing aid, and we listen to the hip in movement in all directions. If it's smooth, then we give the stethoscope back to the nurse. Acetabulum. Now, there are points to realize. There is a secondary adjustment of the acetabulum. When you have both column fractures, namely the anterior iliac spine column or iliopectineal column, and you have the ilioischial column. When both are fractured through a transverse fracture, this is displaced medially. And if it's low and you have a good portion of the sourcil intact, you can treat this patient. Otherwise, if you have, and by the way, this is called the spur sign, and you have a seagull sign, and you have to do measurements of subchondral and the roof arc measurements. You have to study this. What is the chondral arc, what is a roof arc measurement, what is a Siegel fracture, what is a what do you call it? I told you it. It's a fracture of both columns with the protrusion. So this is what I have to say. Look at over here. Let me see what I have to tell you. This is a slide which shows the anterior column and posterior column, and it shows the anterior wall and posterior wall. And you have to know which view gives you a view of the greater of the tuberosity, the iliotuberal is an iliac view. So we can tell a lot about the ischium, whether it's fractured or not. We can tell a lot about the anterior wall, whether it's fractured or not. Coming back to this, you have to think of the iliopectineal column. You have to think of the ischial column and what views will show it most. So if you use an obturator, it gives you a clear picture. If you use an iliac view, it will tell us a lot about the ischial column. So keep this in mind. This is the roof arc measurement that I was speaking about, where you go to the center of the head, you draw a line vertical, and then another line is drawn to the fracture site. This should be 45 degrees in all views. يعني بالobturator, بالiliac view, all views, it should be 45 degrees. And this will tell you whether there is a secondary congruency between the head and the dorsal, which is the dorsal of the acetabulum, the upper margin, and this will save you any surgery. So on CT scan, the area within the 45-degree roof arc also corresponds to with the superior 10 millimeters of the acetabulum, and this is a subchondral. ما بسمع. زهقوا الشباب؟
دكتور جون.
ايه تعبوا؟
لا ما تعبوا.
انا بكمل لبكره عشيه.
واصلين.
نكمل رح بعمل لهم
الحين.
سمري على الباقيين لان انا تعبت رح بعمل سمري.
خلاص اوكي.
So yeah, this is enough. What I forgot was the spur sign. The spur sign is when both column fractures, the spur sign above the acetabulum on an obturator or oblique radiograph is this. Okay, let me see if there's anything I have to mention further. We aim at reduction to within 2 millimeters. Now, the ilioinguinal or iliopectineal, or whatever you want to call it, is the long approach anterior. When you approach only up to the end, just above the obturator, it is called the stopper approach. And this is a safer approach. So don't forget about marginal impaction, rehabilitation, and now we'll speak about the complications, as with pelvic fractures, DVT, is a major concern for patients with acetabular fractures. Prevention includes use of pneumatic compression boots and chemical prophylaxis. Patients who cannot receive prophylaxis should be considered for an IVC filter placement, intravenous and a venous cavus filter, cavus. Iatrogenic nerve or vessel injuries do occur, especially the coxal back sciatic, and this occurs from self-retaining fractures. Heterotopic ossification is present in the extended iliofemoral approach and less in the coxal back. Okay? To prevent this, of course, you all know you give endoseed and you give a dose of 700 CGs radiation therapy. The risk of osteonecrosis is highest when hip dislocation occurs currently with the acetabular fracture. Dislocations should be reduced as soon as possible to limit thrombosis or stretched vessels. Surgical treatment, the ascending branch of the medial femoral circumflex artery should be preserved. Untreated Morel-Lavalley lesions have a high rate of infection. This is a Morel-Lavalley lesion. Look at the hematoma beneath the subcutaneous. This is a we cannot operate. Oh, I took this from the review course, pelvic fractures. Please listen to this. This is very important. It gives you a summary. Pelvic fractures in young adults result from high energy injuries and are often associated with other life-threatening injuries. Rapid provisional fixation of unstable pelvic fractures can be performed in the trauma bay with application of the pelvic binder. Pelvic binders can remain in place during further diagnostic tests, such as angiography. If necessary, a portion of the binder can be cut to allow for vascular access. Open pelvic fractures may require a diverting colostomy because you can have injuries of the intestine, injury of the bladder, you can have all types of organ injuries. Spleen, you might need a colostomy, and the intestinal injuries are not uncommon. Now, external fixators can be used for definitive treatment of anterior pelvic injuries, but not for unstable injuries, not unstable posterior. This is what I was telling you. External fixator will fix only the anterior compartment of the fracture. Diagnostic, ask this question. When you do it, where should you do the peritoneal lavage? You should do it above the umbilicus, not below, because you can get have a high incidence of DVT and pulmonary embolism up to 10%. Acetabular fracture. Secondary congruence of both column fractures may allow successful non-surgical management. I spoke to you about it. intraoperative traction of acetabular fractures can create fracture reduction. Mild action is often seen with posterior wall fractures and should be elevated and bone graft. Morel-Lavalley lesions have a high rate of infection. Heterotopic ossification is common, especially with extended iliofemoral and kosher Lannenbach approach. Now we're coming to sacral fractures. I'm going to speak very quickly. I'm sorry, I have to. Sacral fractures, they are considered a fracture of the pelvic ring. It's a portion of the pelvic ring, and they occur principally in young adults as a result of high energy action. Older patients also can sustain these fractures of insufficient process. The sacrum is the terminal extension of the spine. As a matter of fact, many say that the sacrum and pelvis is a terminal vertebra of the spine. So you have to keep this in mind. The sacrum forms an articulation on either side of the ilium, known as sacral root injury is most common with zone 3. Let me tell you, if you look at the sacrum, it's a V. If laterally, you have the A layer of the sacrum. Then you have the foramina portion. Then it's classified these fractures into the sacral foramina, and finally type 3 in the central portion of the sacrum. Surgical approaches, sacral fractures, and sac joint dislocations can be exposed from an anterior posterior approach. Why am I telling you this? Because at times we can put a screw through this S1 vertebral body, and this will hold well. And the way you did one in front of the vertebral body from the posterior aspect of view, and then put the screw to make sure that screw won't penetrate the cortex in the anterior and posterior direction. So you have to pay attention to percutaneous passage of the screws. So these are important points. And in the anterior approach, you should pay attention where you're putting the plate, because you have the L5 nerve root, which can be injured.
Dr. Jone,
I want to show the radiographic evaluation. You need a CT. The Dennis classification you should know. This is the Dennis classification of how to classify it. And this is the treatment can be non-surgical, it can be surgical. You have to know, have iatrogenic sacral nerve root injury. This can result from improper hardware placement with either open or percutaneous leaks, mallory with vertical displacement fractures, as with any pelvic fracture, and DVT is a risk. So I'm going to come like the other sacral fractures.
دكتور جون
Hey, you want to stop?
لا 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 السلايدات ما بتمشيش، واقف السلايدات.
ما عم بفهم.
دكتور جون السلايد واقف عند يعني واحد من السلايدات، يعني انت عديت على الكلام والسلايد ثابت بالشاشه سلايد واحد.
And
يعني ما
it's not
بيتحرك
showing
الشاشة.
anymore. It's not showing.
Yeah, just one slide. Yes, acetabular fractures.
هلا you see now this slide, sacral fractures.
No,
You don't see any yellow slide.
no, till now no. عندنا
No.
acetabular fracture. Yeah.
ها؟
عندها
بس عند
acetabular
الاسيتابلا fractures وقفت.
وقفت الشاشه. ايوه ما عم تتحرك.
طيب شو لازم اعمل؟ حط نيو
ما ادري
شير؟
والله.
ايه؟
لا بلاش نيو شير، او مثلا شوف كيف.
ريزيوم شير. لا برجع، يا الله رجع لهيدا الشير.
ايوه
يلا لحظة، هلا بينت.
طيب ايوه هلا sacral fractures. اوكي.
It shows now.
Yeah.
Very good. Sacral fractures are often difficult to fully visualize on plain radiographs. You can see that they're in the region of the sacrum. CT is helpful in defining the fracture. Percutaneous treatment is reserved is most common with zone 3 injuries. Over-compression of the fractures should be avoided. When you put through the sacroiliac joint into the body, it should be a fully threaded screw. Or if you're using a partially threaded, you should compress it not very much, because then you can have problems. The sacral root injury is most common with zone 3, yani fractures in the center, in front of the canal. Percutaneous fixation is unreliable in patients. Experiment when I put the screw is to use technique of Mehra, where he uses the finger as a bit protection, as a direct his drill bit in the proper area before he puts the screw in. Now we come to fracture. Okay. Well, this I will tell you. I'm going to go through list ranks very quickly. This is a paper I made. I presented. It was published. You should know that the classification of Lisfrank's dislocations are homolateral, isolated, and divergent. These are very. What is a Lisfrank fracture? A Lisfrank fracture used to happen during the First World War. And with impaction, they would have this fracture. Now, you have to look at the second metatarsal bone. The second metatarsal bone is recessed comparing to the other metatarsals. Now, between the bases of each metatarsal, there is an intertarsal ligament. But between the second and the first, there is no ligament. So you have a ligament between the base of the second metatarsal to the. Keep this in mind. This is called Lisfrank's ligament. ways. Look at the palm or the plantar aspect of this zone of bruising. This tells that they used to say it was a rare injury. Sorry, I want to drink. It was a rare injury, but this is not so. It's quite common. And nowadays, and the mechanism of the injury is becoming more apparent. And the diagnosis of the injury is becoming more common. In the past, they used to diagnose showing the foot. You see the recession of the second metatarsal with respect to the first and third metatarsal, and action between the second metatarsal and cuneiform. Technique across the 5 TMT joints, and one that did not require secondary to frostbite. That's why it was called the Lisfranc. But it is a tarsal metatarsal joint dislocation. في حدا عم بيحكي بده شيء؟
فتحنا المايك لانه فريز جين الشاشه على ساكرال فراكشرز.
ليه هيك عم بيصير؟ معك خبر انه
ما يعني المره الثانيه هو بيعمل فريزنج كذا، ما بيظهر، ما بيتحرك.
ما بيتحرك. انا بدي ارجع انزل لتحت لتحت لتحت، يعني في عندي 1017 سلايد.
1017
خليني اشرح. انا عم بعملها دقيقه هيك بريح صوتي شوي.
كمل باقي شوي.
شوف لا بعد بدنا نكزي. اوكي بينت خالد، بينت يا خالد.
الدكتور جون بينت
اوكي بعجي لحد. So when you look at the essential, this is Lisfranc's ligament. ما تنسوا, this is the cuneiform and this is the base. اوقات بيجي fragment of bone مع، ولما بتعملوا صورة بتقشعوا في fragment of bone, and this is called the fleck sign. The cause of a Lisfranc is a compression force with the foot in plantar flexion. Another mechanism يلي بيوقعوا من الحصان وبيتعلق اجرهم بال هيدي يلي ستيرب يلي بحط اجره عليها وجرشه تعملوا. So if it's not treated properly, and even if it's treated, it can lead to arthritis. Okay, now this shows you these findings. This shows you that functionally the Lisfranc joint can be divided longitudinally into 3 columns. You have the medial column, which is the first ray, the middle column, which is in the middle 2 rays, and the lateral column. And the important point is that this is the anchor. And this is fixed also. But the lateral fourth and fifth are mobile. And when we are operating on it, we don't like to fix these two metatarsals permanently. So we put only Kirschner wires. While over here, we can put plates because the patient is not bothered by it. Now, this shows you the arc in which the base of the second metatarsal is present and is بتقشعه مستحيل to be displaced plantar wood. It has to be displaced dorsal wood. Why? Because they are look طلعوا على الارc. There's no way it can go anteriorly. Measurements over here, have an idea about them. And you have to know that there are certain points. Let me see if there's something I need to tell you about. Etiology, two major causes: low energy sport-related injuries, high energy motor vehicle accidents, tarsal direct load to the joint, or by axial loading of the metatarsal. هيدي البوزيشن تبع الفوت لما بتعمل Lisfrank's injury. Don't forget it. It's plantar flexion and axial loading. In football, how does it occur? بيوقع الكلية على كعب إجر الثاني. بتعمل لك هالبوزيشن وبتعمل لك هالفراكشن. High energy injuries, the method loading is not significantly different from the energy absorbed by articulations resulting. And it's in general plantar flexion with axial loading. You should pay attention to the ecchymosis. If you have significant swelling, pain along the tarsometatarsal joints. Many times it's not apparent, simple AP X-ray. You should ask your patient if you see that there's nothing apparent, but the patient has ecchymosis and you see that the patient has pain, you should ask him to stand on the cassette, put a bit of tolerable weight, and then ask for the X-ray. I want to show you why we judge this by X-ray. If you have a Lisfrank's fracture, you judge it by these X-rays. You can see that the second metatarsal, with respect to the intermediate cuneiform, is displaced laterally. You have to pay attention to this. This is another X-ray ecchymosis. This is something I want to tell you about. When you look at these X-rays, you should look at the margin of each of the cuneiforms. The margin of the cuboid should be in line with the fourth metatarsal. The margin of the intermediate cuneiform should be also in line with the third metatarsal. So keep this in mind. This shows you a Lisfrank's fracture of the cuneiform. Look at the second metatarsal, third metatarsal, of how they are displaced laterally. This bone over here is called the Fleck sign. This is a Lisfrank, but you see that this time it's in the lateral three metatarsals. When you recalled when I told you, it is in an arc. When you have an arc, it will displace dorsally, not volarly, not plantarly. And so all the displacements of a Lisfranc fracture is upward. This is another Lisfranc fracture. You see the cuneiform, you see the margin. It's not in line, not in line. And this tells you that you have a Lisfranc fracture. A flex sign is the fragment of bone over here. It's seen on AP radiograph and is pathognomonic for Lisfranc injury. This sign is reportedly present in 90% of Lisfranc ligament injuries. So, in another important point, they say that the Lisfranc ligament is strong, and for this reason, it avulses a portion of bone. This is another injury. You see, there's a gap here. You see that there's no longer alignment between the cuneiform and the metatarsal. This shows you a Lisfranc injury occurring. This was a diverging injury. You see, it has occurred at 2 levels, and you can see the gaps in the coronal. Magnetic resonance imaging has an advantage in identifying partial ligament injuries and subtle ligament injuries, but CT scan helps us more. So I would like to see what we can do. Management, I will show you very quickly the management. Management on this diagram. We like to put screws medially and pins laterally because these are mobile. We don't like to mobilize them because the patient won't through the cuneiform to the base of the and then you put these screws and the patient. You don't have to do a primary fusion. You just put them and hope that is to reduce the dislocation and the fractures to anatomical alignment. This shows you a case that was done in this. Now, the problem with this is that you cannot leave the screws in all the time. This can break. So for this reason, some will remove the screws after 8 months. Others leave them in permanently, and they state that about Lisfranc fracture. First of all, it's falls from second of all, it falls axial compression and plantar flexion. An axial force into these. You have to know in line with the cuboid. Complications. You have to think this injury is a severe injury, compartment syndrome, after a major trauma. Don't forget about the number of compartments in the foot. Non-anatomic reduction or alignment is to be avoided. Post-traumatic midfoot arthritis is a very common complication. Painful hardware. hardware failure or breakage, a flat foot deformity with instability with weight bearing can occur. Don't forget that you can get regional pain syndrome, just like you get in the wrist when you use the Perpendji pins. Neuromas do occur. Infection is common and wound complication. You can have vascular injuries, and as a result, they can end up with gangrene. Along this joint line, continued chronic pain with weight bearing is best treated with fusion of the first, second, and third tarsometatarsal joints. Is are the first, second, and third, but not the fourth and fifth, because these are mobile. We need them. With alignment and stabilization of the medial joints, laterally based pain usually subsides. Is a this is a fusion that was done. Is a Pintibo, il fourth and fifth were not included in the fusion. This is a lateral Lisfranc injury. We know that we have a medial Lisfranc, we have a diverging Lisfranc, and we have a lateral. This is a lateral. It's going this way. If you have a diversion, this will go medially and this laterally. And if you have a medial, only this will go medial. So keep this in mind. Now, we do put plates and do primary fusions or secondary fusions. And these are plates mainly for Lisfranc. And you put bone and put the plate on them. This is being applied. Prognosis, stable anatomic alignment is the best predictor of outcome. The presence of fractures and or articular structure destruction leads to poor results, regardless of alignment. The Lisfranc's lesion. Now, you have to distinguish between Lisfranc's lesion or fraction and the Charcot arthropathy. Charcot arthropathy, such as occurs in diabetes or any of these insensitivity to push this. Mechanically is a hadan between this and this, say that both are very different. This is the flex sign. I got this. I was lucky to find it later on. You see that the support is really gone. This is a few cases of fusion. You have to monitor these patients a lot. You have to look over here. This is how we operate. And even we put the plate on the plantar aspect. So, in conclusion, there is mid-foot swelling, usually dorsal. there is pain on palpation of the tarsal metatarsal, and these are the incisions we use. And you have to study on your own. So this is, in my opinion, enough for this. Now, the last fracture I will be discussing is the tibial plateau. I want to reach to it. But you have this, you're recording it. ما هيك خالد؟ fractures غريب. ليه عم بيصير هيك؟ في حدا عم بيلعب بالسلايدز. I want to find this is it. Tibial plateau fractures. I have something to tell you about tibial plateau. We use the Schatzker classification into 6 types. You should look at the Schatzker classification. The problem with the Schatz is that it does not tell you anything about the posterior aspect of the tibial plateaus. Another point I want to mention, is that plateaus are different in height. The medial plateau is concave, while the lateral plateau is convex. The lateral tibial plateau. And the reason why is that you have less trabeculae than you have on the medial side, and therefore you get more fractures. The first 3 components of the Schatzker are the tibial plateau, ranging from a simple joint articular depression to a slit fracture. And this is a simple fracture. You should pack it with bone. I want to see as I move. This is a lateral fracture. Look over here. You see the way it is fractured. Why not the medial? It's very rare. But this is a type 5 fracture if you look very carefully, because you see the medial condyle, you see the medial tibial plateau, and the lateral plateau being fractured. We have a bimodal distribution between males and males is usually the highest incidence is the 4th decade, and female, the peak is 7th decade, osteoporosis. Now you should think of also the lateral plateau and bicondylar medial plateau fractures syndrome. You should rule out medial collateral ligament and ACL ligaments and meniscal tears, and look for the soft tissues. So the Schatzker says 1 is a fracture, and 3 is a pure depression fracture. These we can treat very easily. Is the fragment and put bone graft underneath it, then insert our raft screws. The type 4 is a fracture that we don't like. First of all, dislocation can occur with and reduce spontaneously by behind, which is fixed at the ductal canal and fixed at the arc, the soleus arc, 2 areas. And when you have this dislocation, it stretches. You can injure the popliteal artery, and many of the patients can have an immediate up even with an amputation. In 5, it's a bicondylar fracture, both plateau, and separate diaphyseal fragment. Yani, this is 6. I want you to see it. This is 5. You have both condyles fractures. And this is type 4. Now, you have a class 41A extra-articular, B partial articular, and combined C. مشان ما تزعلون للAO, you should know this classification. Now, plain films, AP lateral oblique, CT, this should be done. Non-operative indications are less than 3 millimeters step off, stable knee full extension, less than 10 degrees varus or valgus instability. You can put the patient in a hinged brace. This is operative indications where the articular step off is more than 3 millimeters, condylar widening more than 5 millimeters, and all medial plateau fractures, all bicondylar fractures should be operated on. Okay, this is how we put our plates. We put usually transverse fractures at the subchondral region so as to hold the fractures in place together with bone graft beneath them. This is a fracture which has an increased risk of post-traumatic arthritis instability and worse results with meniscectomy. So you have to remember that Chatzker does not come other classification that we divide into medial. I want you to know this: medial, lateral column, and posterior column. Medial, lateral, and posterior column. The posterior column is important. You can approach it by 2 means, either medially or laterally. Laterally, you have to approach it behind fly a small buttress plate. And medially, you have its approach. You should know the approach. Okay, so this is what I want to mention about posterior tibial plateau. Okay, so I will end here. And I tell you, I hope I did not trouble you very much. Thank you. I want a straightforward answer. Did I help you? Did I help you?
Dr. June, thank you very much.
I help you.
For this review first. You listen me, Dr. June.
طيب ليك ما تنسوا السيجرتس. سيجرتس بدي اياكم تحفظوها. بعدين عندكم هاي انا ما اعطيتكم كل شيء لان انا ما عاد في احكي هلكت بس بقول go through it and go through the secrets. Remember everything in it and you will pass the exam. Another important point, ما لازم تفرجونا انتوا فزعانين. لازم تفرجونا انه you are sure of yourself. Please pay attention to these points. Okay?
Thank you very much, bro.
يلا بقشعك خالد بالبنغازي. يلا. Good luck to everyone.
Okay, thank you very much.